Good morning. Good morning. This is the first participatory part of the morning. So everybody, good morning. All right. So it is 10:01. When have you been at a conference that actually starts right on time? A very uncommon event. First, I want to thank all of you for being here today to talk about this really important topic. I should introduce myself. I'm Dr. Patrick Conway. I'm the Deputy Administrator for Innovation and Quality at CMS and Director of the CMS Innovation Center. This really exciting day for me personally and for all the staff at CMS. I do want to thank all the staff that planned the event today. A ton of thinking went into this and really important topic, and we look forward to partnering with you throughout the day. I have 7 days left at CMS, which is bittersweet in many ways, and will be going on to be CEO of Blue Cross Blue Shield of North Carolina, trying to build a model Blue Health plan. I was just kidding in the back. Not only do we want to deliver mental health parity, my personal goal would be mental health and behavioral health parity plus. So how do you actually have even better care in the mental and behavioral health arena than in other arenas in healthcare? How do you really try to be a model health plan? And I know CMS, which is going to be our focus today, also this is a major focus area. The CMS Innovation Center is responsible for testing new payment and service delivery models. We have done some work in mental and behavioral health. We're here today because we think we have not done enough work, and we want to hear from you, given that this is a priority area moving forward for the administration, for CMS, for the CMS Innovation Center, and we all think we can do better in the mental and behavioral health arena. We want to hear from you. How can we do better? I was talking backstage. There's a number of priorities we have going forward where I'm pretty sure what the payment models are and what we need to do. This is an area where I have some hypotheses, but our team really wants to hear from you. What are the biggest impact things we could do? And I challenge us all to think outside the box. Backstage somebody said, what if we deployed as in a national emergency fashion and had funding for the Public Health Service Corps to address some of these issues directly? What if we had an all hands on deck, every single lever in a state and locality to see what's possible in a state and a locality to drive change? So I'll encourage us all to really think outside the box. On a personal level, like many of you, this issue has touched my life. I think we'll hear from experts on substance use disorders, mental health disorders in the presence of co-occurring conditions, Alzheimer's disease, behavioral health workforce challenges. Feedback from the summit will be used to shape future work for the CMS Innovation Center. And we can never obviously promise exactly what model we can do, et cetera, because there's a whole government process as we launch models, which we know well, and we will try not to bore with you with too much today. But we do promise to listen, to learn, and to try to directly apply the work today. Today's summit will be moderated by Chris Ritter, Director of the Patient Care Models Group at the CMS Innovation Center. I now have the pleasure to introduce the Honorable Mr. Patrick Kennedy, who will deliver the open remarks. He'll be followed by Dr. Terry Klein. Mr. Kennedy spent 16 years in the U.S. House of Representatives, serving Rhode Island's 1st Congressional District, fighting to end discrimination against mental illness, addiction, and other brain diseases. He is best known as the leading sponsor of the groundbreaking Mental Health Parity and Addiction Equity Act of 2018. Since leaving Congress in 2011, Mr. Kennedy has kept his promise to do everything in his power to fully enforce the parity law and to push for greater global investment in brain research, which he has called the next great frontier in medicine. Toward this end, Mr. Kennedy founded 2 innovative nonprofit organizations that are changing the lives of people with mental illness, addiction, and other brain diseases in the U.S. and around the world. He's now serving on the White House Commission on Combating Drug Addiction and Opioid Crisis. On a personal level, I had the pleasure of attending a Kennedy Forum event in Hyannisport, and 2 important things from that event. Most importantly, it actually led to a lot of CMS's work to implement the collaborative care model, and Dr. Matt Press is here who helped with that, and many of the CMS staff, but to implement nationally the collaborative care model, including outcomes measurement. So I want to thank Mr. Kennedy and the Kennedy Forum for that. Secondly, my wife and 4 kids got to play in the theater in the basement, and he watched nicely, I don't know if he remembers this, and really enjoyed the event. And my wife said afterwards, and I've brought her to the Oval Office, I've done all sorts of things with my wife, she literally said, I don't think I've ever told you this, that because her parents' house was across the water from them, that this was the best event she had ever had that I had taken her to. So I want to thank you for that as well. Appreciate it.
Thank you, Patrick. Thank you, Patrick. And thank you, Dr. Conway, for your incredible service to our country. You've held such an important place of responsibility, overseeing the largest payer of health care in this country. And you've been willing and interested in trying to make sure that finally mental health and addiction is properly paid for and included in all CMS policy, including this conference here. Even as you're hitting the exits, Patrick Conway, you are leaving your mark on this fantastic organization by helping usher it into a new direction, one that will finally treat brain illness as the illness that it is and not as something else, something other, only to be relegated to the margins of our healthcare system because our payment system relegates it to the margins. So I want to say that there was a little manipulation in getting you to come and help endorse the collaborative care codes that we are so excited that CMS put forward. And that was knowing of your ancestry and just looking at you. I knew that if I invited you to sit in the chair that President John F. Kennedy sat in as he hosted cabinet meetings while President of the United States, that somehow that might be a compelling reason for the chief medical officer of CMS to come to Cape Cod and listen to our arguing our case for collaborative care. And I was happy to babysit your children. I was happy to babysit your children because I knew you were in the room with all of the biggest insurance companies. And all of them were wondering what was going to come out of that meeting. And I'll never forget everybody going to lunch and Dr. Conway pulling me aside and saying, "Congressman, what do you want me to say when they all come back?" And I said, wouldn't it be nice if after having heard this explanation from Jürgen Unitzer from University of Washington about the power of the impact model and collaborative care, 80 randomized controlled trials, that CMS was going to begin to think of all the different ways that they could reimburse for collaborative care. He said, I'm happy to do that. So, of course, he goes in there. We got all of the big payers come back and sit down with their sandwiches and said, so we got to talk about this morning's session. Dr. Conway, what do you think? Well, Congressman, I think it would be an important thing. In fact, I've already been emailing my staff back at CMS that we ought to be really reimbursing for these collaborative care codes. All of a sudden, Sam Nustrom dropped his sandwich and went right on his iPad and started sending messages out to Indianapolis, where Anthem is headquartered. And the same happened with all of the Aetna and Cigna and Humana, all of the insurance folks, which tells you something. And that's the reason we're all here today. That CMS has a powerful, powerful voice in how insurance overall is organized. So as CMS goes, so doesn't the rest of the insurance community, because they all take a page from what CMS reimburses. And that is why today's conference is so important. Let me just outline a couple of things and explain, my thinking behind them, because clearly I've relied on many of you in this room in order to come up with the recommendations that you can find at the KennedyForum.org online later today, where you can also find our members' guide for members of Congress navigating the new frontier of mental health and addiction. When I was in Congress, I found it shocking that if you cared about mental health and addiction, there wasn't a place to go where you could get the A to Z of issues that could help us tackle, and that there wasn't a guide that would show that no matter what committee in Congress you were on, you could do something to help address the mental health and addiction crisis in this country. In other words, it didn't have to be the Subcommittee on Energy and Commerce that was the only committee that took up issues of mental health and addiction. In fact, it was probably going to be the housing and HUD budget that would have as much, if not more, than any other agency to do with mental health, but nobody knew it yet. Or it may be the education budget because of the importance of doing better screening and identification early on, given the onset of these illnesses being illnesses of the young, but nobody knew that education department had anything to do. Or it could be the Department of Labor and the fact that DOL oversees all ERISA plans. But of course, most members of Congress would know that all of the regulatory authority overseeing all of the big payers is in the Department of Labor in terms of the regulations. My point is, and I know this is patently obvious to all of you because you often work within this beltway, understand the ways that it works, but frankly, there is an illiteracy out there in terms of what it is that members of Congress can do to tackle this crisis besides just taking a one-off approach that is often the only approach that we take when coming up with a complex issue like the opioid crisis, or with the complex issue of how we're going to adequately deal with the suicide crisis in this country. So we need to have a comprehensive approach. I couldn't help but think about today's conference when I heard how FEMA was beginning to orchestrate a response to Hurricane Harvey, and how they were even beginning to forward deploy their resources to address the impending disaster of Hurricane Irma. And they all said that the benefit of FEMA is that it was finally able to do a comprehensive approach to addressing a national crisis by including all federal agencies in the answer to that challenge. This FEMA was created as an act of Congress back in the 70s because the governor said we couldn't do a one-off approach anymore. We needed housing, job training, health care, transportation, and on, all to be part of the response to any natural disaster like what we've seen in Harvey and what we're beginning to see with Irma. That, my friends, is the template to deal with this tragic crisis of opiate overdose and suicide in our country. It must be a FEMA-like response. In other words, in order to tackle this challenge, we need to take a full picture of all the attributes that will support a community and all the liabilities that bring a community down, irrespective of the fact that those are healthcare issues or whether they're human services issues. And I think that the takeaway from today's conference will be how much can we incentivize through CMS funding the kind of wraparound approach to dealing with real-world challenges in a real-world way, and not in a one-off way that is often the way we're relegated to respond to these crises, because that is the only way we get paid. So the innovative models that you're going to be talking about today, which I talk about in my testimony, are all about how to deal with maximizing the different aspects of reimbursement paired with state resources, paired with private payer resources in order for us to try to put together a population health solution, especially at a time where we're under assault in terms of the undoing of insurance through the attack of the ACA. And let me just be one of those people to say quite clearly, there is no way of attacking the opioid crisis or the suicide crisis unless people are insured. I know this should be obvious, but let me just state it again. There is no way we're going to be serious about attacking this opioid crisis if we don't have people insured, which means we can't provide the kind of support and care for them that they need over a time that revolves around the chronicity of their care and provides a continuity of care and a continuum of care that's only possible if we're paying in an insured environment. If we go to block grants, we are not going to be able to sustain any of the innovative changes that we're trying to leverage through the payment reform mechanisms that CMMI is going to be talking about with all of your help today. But let me just finally just make a few concluding thoughts before we have question and answers with Dr. Terry Klein, the commissioner out in Oklahoma. And that is, any payment reform cannot lock in the same discriminatory reimbursement practices that we have historically seen by CMS. Let me just state it perfectly clear. I have traveled this country over the last 2 decades. I have spoken at every part of this country. I have met with every single stakeholder in this country, and CMS does not pay for, does not reimburse for mental health and addiction in the same way that it reimburses for medical and surgical care. I have on my team at the Kennedy Forum one of the lead litigators on parity compliance. In fact, this litigator settled some of the biggest insurance claims in this country in terms of fail first, in terms of other denials of care by some of the biggest insurers in this country. And if he were to put together a lawsuit taking the facts of CMS and the reimbursement levels of the behavioral health providers when compared with medical and surgical, he would have CMS in a consent decree because of the historic discrimination that continues to persist in CMS reimbursement practices. When we're thinking about new bundled models of care, we have to first fix the poor, shoddy, tragic reimbursement rates in the mental health and addiction space, first and foremost, because otherwise we're going to lock in the historic double standard that we've already seen in CMS reimbursement in terms of mental health and addiction care. 2, when we come to putting together these new bundle payment models, we have to ensure that those who are providing that care adhere to real outcomes, not process outcomes. Not process outcomes. We want to see outcomes-based metrics. We want to see severity scores improve. That needs to be the metrics. And understand that many of these providers themselves are guilty of a historic discriminatory mindset. So I'm not laying blame just on CMS. I'm here to say there is equal culpability across all of those in this country when it comes to not treating mental health and addiction in the way that it ought to be treated. The only way we're going to get past all of this is through the kinds of attentions that you're going to see brought to issues that are raised today. So I thank you all for being here, and I appreciate the opportunity to participate, and thank you so much.
Thank you, Congressman Kennedy. Certainly raised a lot of important issues for us to consider, and love the passion. I'd now like to introduce Dr. Terry Klein, Oklahoma's Commissioner of Health. Dr. Klein previously completed a post as a health attaché at the U.S. Embassy in Baghdad, Iraq, where he advised the U.S. Ambassador, the Iraqi Minister of Health, and the U.S. Department of Health and Human Services on health-related challenges in Iraq. From 2006 to 2008, Dr. Klein served as the administrator for the Substance Abuse and Mental Health Services Administration. Prior to that, Dr. Klein held the position of Oklahoma's Commissioner of the Department of Mental Health and Substance Abuse Services and Oklahoma's Secretary of Health. So Dr. Klein has a lot to teach us, both at the federal and state level, about these issues. Dr. Klein is involved on a number of local, state, and national efforts that focus on improving the overall health of the community and the nation. Please join me in welcoming Dr. Klein. Thank you.
All right, good morning, everyone. All right, you got a ways to go. I know the energy's out there. You've had 3 welcomes. Patrick, thank you very much for the introduction. Thanks for the invitation to be here, and thanks to the Innovation Center for hosting this. So I want to make clear, if it wasn't clear after Patrick Kennedy's comments, I'm really impressed with CMS. There was no censoring of comments. Could you pick up on that from Patrick? Right. And that is impressive. It's like, this is about innovation. It's about putting all ideas out there. Nothing is off the table. It's all on the table. And that's pretty remarkable, especially for a federal agency. So I'd like to say thank you for that open invitation to be here and to speak our minds. The lesson learned for me is, if you ever do a session with Patrick Kennedy, make sure you go first. It'd be much, much easier that way. He did a fantastic job and just incredible energy and experience, both life experience as well as professional experience. So I was trying to think about why I've been invited to be here. So I'm going to just touch on a few kind of touchstones for me, and the reminder in speaking to all of you. I know I'm speaking to a room of experts, which is always dangerous territory. You know more about the issues of insurance and coverage and codes, certainly, than I do. So I'm not going to go down that path. That's really up to you. That's why you're here. I'm going to put a little bit of meat on the bones about why many of us, if not all of us, have gone into this particular field. And it's about people. It's about people's lives. It's about change. It's about improving the quality of life for those individuals. So a few touchstones. Some of the things that don't quite make it into your bio and your intro may actually be more important than what is spoken about as part of that official bio. So I'm going to start back and just quickly run through this. So I was of the era, and actually remembering when the first person stepped foot on the moon. Pretty cool. I was 11 years of age when that happened. So you can imagine how exciting that is for an 11-year-old, right? Just that sense of adventure, that sense of discovery and the excitement that comes with that. It was an incredibly exciting era. And it really planted some seeds for me about this sense of there is so much that we can learn, and really nothing is out of our grasp. Nothing is impossible. Because people just, at one point, couldn't imagine being able to pull that off. 9th grade, my first psychology class, right? That's when you get that. I have to tell you, this is an exciting conference for me and Summit, because this is all about the brain. And these are all brain illnesses, all grouped together. At a time when you see entire institutes, when you see funding streams that work very, very hard to keep that siloed. So again, thanks to the Innovation Center for bringing all that together under this umbrella, which is really about the brain. So as a 9th grader, hearing this for the first time, I decided right there on the spot, I'm going to be a psychologist. That's how I learned that, 9th grade. And I did. So I became a clinical psychologist. I ended up doing an internship at Children's Hospital in Boston, and then doing a fellowship after that, and I loved it. I was ready. I was primed to change the world one person at a time. And I actually specialized in child and family. It just made sense to move upstream a little bit. Let's not wait until we have problems. Let's wait and grapple those right now. Let's not put it off until someone has 10 or 15 years of a struggle on their hands. Let's move upstream. So start working with kids. And that's what I did. So my very first professional job was providing home-based family therapy, basically in people's homes, people who were struggling with a whole array of issues. And at that time, I didn't have the language, but it's become commonplace now, really talking about those social determinants of health. And one of the big drivers was poverty, incredible poverty. So even though I was doing this work in Boston, in Cambridge, Somerville, some people think that we don't have big neighborhoods where these issues are challenged, but we do. We certainly do. And that was a wake-up call for me. Going into the projects, again, the identified patient was a child, but these were kids that were either being reintegrated into their homes because they had behavioral challenges that were so significant, schools couldn't handle them, community systems couldn't handle them, the families were having trouble maintaining them within the home, and so they had been booted. And so you go off to residential school, maybe for a year, maybe for 2 years, and then you come back to the exact same environment, which, as many of us know in our histories of substance use, many times when you're off to a rehab program or a treatment program and you come back and there hasn't been any work with the family at all, we really shouldn't be surprised if there is relapse in that environment. If we haven't made that connection into the community where the person lives and works and goes to church and spends time with people in that community, we should not be surprised by that. So when I went into these projects, the eye-opening experience for me was a whole world that I had not experienced. As someone growing up in a relatively small town, my dad was the director of a YMCA right there in the community, mind, body, spirit, whole health. I mean, I had it all, what we needed to do here. But what I encountered, not just poverty, but the incredible multiple generations of substance use, child prostitution, gang violence, incredibly violent homes and violent communities, people who were engaged in incredibly abusive situations as well. That was an eye-opener for me. And it really made me realize how unprepared I was. I would say I used maybe 10%, maybe 15% of my training to do that work. A lot of it was about connecting with people. It was about doing the work of making sure that people could utilize the resources that were available and hanging in there with these families. So a couple of examples. One was a 3-generation family all living together in a nice row house in Cambridge. Italian family. The grandmother had immigrated from Italy, and it was a very matriarchal family. You had the grandmother, the mother, and the granddaughter. The granddaughter, again, was the IP. About 14 years of age, having trouble in school, accused of having promiscuous behavior, starting to use drugs, and incredibly violent interactions with her mother. She was about to get kicked out of that home and to get kicked out of that community. Now, because this program allowed me to actually do home-based work, that was a huge advantage. Because the grandmother, she was not going to have anything to do with these therapists. It's not the way you did it back home. So the first time I went there, grandmother was nowhere to be seen. She wasn't about to show up there. So I worked with, you work with who you have. So I had the mother and I had the daughter. And so we started meeting right there in the kitchen. We would have these. And after about the second session, probably on the third session, I thought I heard something down the hall. And all of a sudden I hear this, "That's not true," with a really, really loud Italian accent. I'm like, what's going on here? That's grandmother, don't worry about her. She was down the hall listening to every single word that was being said in this session. So over time, the grandmother who ruled the roost for this family, absolutely, moved closer and closer and closer, and eventually was in these meetings. We had great resolution of the issues. Took about 3 months, but it was a very innovative model. It was actually funded by HHS as a kind of a trial program to see what we could do if we had more flexible funding and more flexible services available to this family. Another family that really crosses over both the mental health domain as well as the physical health domain was a family in Somerville. Mother and father had been divorced. Again, the IP identified patient was a young boy who was about to get kicked out. The whole family, incredibly bright individuals, really, really bright, a lot of strengths in this family. The family also, the father had diabetes, was actually blind as a result of his diabetes. Both kids had diabetes, which contributed kind of mood swings with blood sugar fluctuations for the boy and challenges, and an incredible learning disability, all packaged together. At that time, with this 8-year-old who was struggling mightily just to be in school, even though he was incredibly bright. So that work really took working with the entire family. Even the parents who lived in separate residences but had co-responsibilities for the family and the kids came together to do this work. It was incredible being able to see that. So there was a different model that allowed us to do the work that actually made a difference. So that was over 20 years ago that was taking place. And about 2 years ago, I heard from that mother in that particular situation who had found me on the internet just doing her Google search, and she sent me pictures of the kids and how they're doing with their families now. It was very, very touching and very thoughtful on her part to kind of close that loop. So we have this opportunity to touch people's lives. And in doing that work, mostly in Cambridge, that was the decade of the brain. Anyone remember the decade of the brain? So it was actually declared by the president, this will be the 1990, this is the decade of the brain. We are going to make a commitment to research and science and make sure that there is funding to actually understand how the brain works. Incredible advances during that period of time. Kind of as Patrick was saying, it takes an all-hands-on-deck commitment to make something like that happen. And then the decade following the decade of the brain was an incredible time of revelation as well, with a lot of translational work and that work that needs to continue. Meanwhile, we're sitting with our challenges today and what we need to do. A more recent story, 2 stories, and I'm closing out. One was as the Commissioner of Mental Health in Oklahoma, I had the opportunity to visit one of our old psychiatric hospitals. How many of you have been in some of the old psychiatric hospitals? The vast majority. So you know, in being there, it's a different world. I mean, there are a bunch of abandoned buildings that are no longer needed. We had thousands of people in each of those institutions who are now in communities. But going into one of those abandoned buildings, it was just a life-changing experience for me. I was able to see one of the small cells where someone had spent years of her life in this small cell. And there were literally scratch marks on the back of this door. I mean, it just tears my heart apart to think about the conditions that some people were in. But the humbling part of that experience for me was that was the best we had to offer. It was. That was state-of-the-art care at the time. So it was better than being chained to a bed in a dark basement and not being fed. It was better than being locked up in someone's attic or being abused by people repeatedly who didn't understand the illness that you were living with and struggling with. That was the best that we could do, but it was state-of-the-art. So I put that challenge out to us today. I hope that we look back at this era and understand that we're doing the best that we can now, but it is not good enough. It is not good enough. People deserve better, and we can do better, but it will take innovation. You all as providers, as systems representatives, have an incredibly unique opportunity to change people's lives. And I have confidence that you can do that. Agreed, CMS has a great leadership role, and part of that leadership role is facilitating the conversations, allowing that innovation and encouraging that innovation to occur. what we're doing now is not good enough. I look forward to the day when we look back and all agree how barbaric the medications, the interventions that we have today are, but it's the best that we can do in the moment. But we cannot stop. We cannot rest at this point. So I want to thank you for taking the time to be here today. I hope that you fully engage with this opportunity that you're being provided. We know through research with Alzheimer's, by the way, my mother was taken by Alzheimer's about 4 years ago, so I know this issue very dearly. 5 million people living with Alzheimer's. 5 million. It's going to triple if we don't change that trajectory over the next 30 years. Triple. And for untreated substance use, whether it's illicit drugs or alcohol, about 20 million people in need of treatment. 20 million people in need of treatment who are not getting that. Huge gaps. So we can do better. We can. And I'm confident that you're bringing solutions, ideas to the table. I wish you the best, not just with the work today, because I know you're just an interloper for this one period of time. You're going to go back and continue to do the hard work that needs to be done. So I wish you well with that work, and I just want to welcome you here and thank you for everything that you're doing. Take care.
Thank you, Dr. Klein. Really appreciate the insights you provided today. I'm going to turn it over to Chris Ritter, who I believe is going to facilitate our Q&A.
They can, or here, it doesn't matter. Over here? Do you mind? No. Welcome, everybody. My name's Chris Smith-Ritter. I'm the director of the Patient Care Models Group, and I work for Dr. Conway for one more week. And we don't have a lot of time built into our schedule for Q&A, but I think we wanted to have the opportunity, I think, to ask both Dr. Klein and the Honorable Mr. Kennedy a few questions. I'm actually going to start and maybe ask the question that we at the Innovation Center need answered, and we'll see how much time we have at the end of that. And I think that really is, if there was one thing we would do first here at the Innovation Center, understanding that it takes all kinds of resources and people to pull together a new approach, and we wanted to focus in your mind across all of the areas that CMS touches, which could be multi-payer, Medicaid, and Medicare. What is the one place we should go first?
Well, first, I think the answer is we need an overall culture change. A culture change. We're losing people at a record rate, and yet these issues are being largely neglected by our system of care because we don't pay for them, and because there isn't the same sense of urgency and application of know-how to mental health and addiction and dementia and all of the issues that revolve around a large portion of our country's population. There isn't that cultural dimension. We need to do this and do whatever it takes to get it done. And CMMI has a perfect opportunity to model, especially in collaboration with many of these states that are doing innovative projects, how you can blend various forms of funding. Because the key to this is not resting with CMMI alone or CMS. It's going to be resting with their ability to leverage their leadership with the other private payers out there. Because we're in a crisis, and we're also fighting defense in terms of the repeal of the ACA and the subsidies for insurers to stay in the market and take care of everybody. So, you know, we're like kind of fighting on all fronts, but the only thing I could say is hopefully we'll bring that same effort that we have brought to Harvey and that we're beginning to bring to Irma towards this crisis. Because it took us 2 years to get $1 billion and 2 weeks to get $8 billion. And if we could see the people with addiction, dementia, mental illness be lifted on crates into helicopters, if we could go interview the families who've been impacted by these illnesses in the same way we've been able to see on TV every time we turn on the TV, I guarantee you this country would have an equal, if not a greater, financial commitment to these issues than it has today. So I would just say, CMS is going to be called on to do this. Ideally, the president is going to make good on his initial call for this to be a national emergency. And if we say that this is what it's going to cost to deal with these other national emergencies, I think it's going to be hard for us to justify doing any less for the opioid suicide crisis than we're currently doing for Harvey. And they're predicting Harvey's going to cost this country over $120 billion. Imagine what this country could do with those, even half of those dollars going to the mental health and opioid crisis. So all I would say is help us get ready, because if we push out a bunch, I'm talking as if I'm still a member of Congress. If we push out all this money in some emergency supplemental, the states have to be ready to know how to spend those dollars. They can't be wasting it paying for things that aren't evidence-based. 10% of the treatment providers actually practice the evidence base out there, which is medication-assisted treatment. There's an indictment on the American Medical Association for the fact they have not stood up and said that this is the evidence base, and any physician has taken the oath ought to be out there trying to provide medication-assisted treatment instead of the opposite, which is there's very little uptake amongst any physicians in helping to meet the MAT crisis in providers. So, you should be reimbursing with a bump payment for MAT, by the way, because we're not getting any uptake. Someone's got to light a fire under these physicians. And I don't care who they are. They could be any type of physician out there. They need to be enlisted in this cause.
Dr. Klein?
So I clearly am a slow learner because I said I shouldn't follow Patrick. And here I am following Patrick. So maybe on the second time it'll sink in a little bit. One of my favorite quotes is from Dr. David Satcher, the former Surgeon General,
Yes.
Who said the difference between knowing and doing can be fatal. So we have an incredible wealth of information. We have a lot of information about interventions, about treatments, about evidence. We know what works. And there's still more to learn. But we are simply implementing a fraction of what we actually know. In the conversation we had earlier, I think it's a combination of things. And part of that is political will to do that. I think you actually have an incredible opportunity in partnership with the Innovation Center to look at different models. I'm a big fan of the triple aim and the challenge with that. I remember a legislator saying to me one time when I was begging for money, I can give you money to keep somebody in a nursing home, or I can give you money to help prevent someone from going into a nursing home. What do you want me to do? I don't have enough money to do both. That's a sad testament of who we are as a society if we can't do both. So we need that political will. We need the will of people to help shift that and to help change that. I think the opportunity that you have as funders, as providers, as systems organizations is incredible. I've been out there when some of the reimbursements have changed for diagnostic codes. It's amazing what a shift occurred when all of a sudden now we're reimbursing for this, and there's a huge emergence of this disorder that didn't exist before. Or kind of the instant recovery that comes after 16 days inpatient, and it looks like, well, your insurance ran out after 16 days. That tells me that the payment systems have an incredible influence on those providers, rightly or wrongly. I think we need to recognize that payment and money has an incredible opportunity to influence change and improve the plight of people who are struggling with brain disorders.
I'm going to give Dr. Conway a chance to say something, and then we'll have to move on to the first panel.
I'm mainly listening, but which is my mode of operation. No, I mean, Thank you for the opportunity. I think the knowing to doing point is critical. I think its multifactorial aspect is going to be critical. I think the payment issues are real, and we need to do more in those arenas as well. I said this earlier and I know you all know this, it's like telling you things you know. The evidence, and I'm a data-driven person, says that we are dramatically trending in the wrong direction in mental, behavioral health, and substance use in this country, and that's having huge negative effects on our population, both most importantly in terms of health outcomes, but also in terms of cost. I do think we should treat it with a level of funding, desire, will, testing, innovating, et cetera, to meet that challenge. That's why we're having the discussion today. I do think CMS can serve as an effective convener, which is also why we're here today. And I know our team is passionate about this work and wants to work with you all on achieving dramatic results. I also think some of this may be showing what can occur in a given state or community as a model for the rest of the nation, and then spreading those learnings. Thank you for the opportunity, and really appreciate both of you coming today.
Thank you.
So I think that's that. We've lost our time for Mr. Kennedy and Dr. Klein and Dr. Conway. So let's thank them all for their public service. I know. I think the exit has to be out this way. Thank you very much. Thank you. Thank you. So welcome, everybody. I wanted to do a handful of small housekeeping items just so we do them quickly. If you haven't been here before, I know many of you have. There are restrooms down the hallway to the left in case anybody needs to use those. Had a little coffee this morning, all good. We have staff volunteers that are wearing their badge, and it has a green ribbon on it. So if there are any questions, anything you can't find, anything you want to know that hasn't been answered or you can't find one of us, again, please reach out to them. They work here very hard, usually not in a voluntary conference staffing capacity, usually doing analytic work, and they can certainly help and assist. For those who are interested, there'll be a recording and transcript. Additional information on when that is available will go up on the Summit website, especially for folks who were not able to be here today. We did have quite a large response, and we wanted to make sure that even if you couldn't be here, you could participate. And also, we won't be able to take questions from the phone due to some technical challenges, and I also think just generally corralling the conference. But we do have an email box, which I know the team is going to make available during all the different sessions, and if you want to send in a question, we will be monitoring that box closely. You got to cut us a little slack. It may take a little bit of time to get back to everybody, but it is a live box. We've been in it, and we'd be looking for additional questions as they come forward. So I want to start by welcoming Dr. Fran Jensen, there she is, for our first panel on, what are you doing? Substance use disorder. Here she is.
Good morning, everybody. It's really quite fun to be here. I am the Deputy Director of the State Innovations Group at the Innovation Center. I'm one of the longest members of the Innovation Center, so it's been really fun and amazing to watch it progress. And I've been working on the substance use disorder since I was in medical school, trained at Johns Hopkins. Baltimore's a very affected community, so it's great to see everybody here all working together. And I encourage you to keep paying attention. So today it's really a challenge being vertically challenged. So anyway, I'll let the organizers know. Anyway, today we are joined by these distinguished guests and experts. We will hear from Dr. Sean Ryan, who's in the middle, I believe. He is the President and Chief Medical Officer of Brightview Health in Cincinnati, Ohio. He's our provider perspective. Dr. Tammy Mark is the Senior Director of Behavioral Health Financing and RTI International. He's worked on this for quite some time. And finally, Carlos Hardy, Founder and Chief Executive of at the Maryland Recovery Organization Connecting Communities, a fabulous panelist who can provide us the community perspective. So welcome. Dr. Ryan, you may begin.
Good morning, everyone. Maybe. Are we on? Good. Good morning, everyone. Again, I'm Sean Ryan. I'm a dual board certified emergency and addiction specialist, so emergency physician and addiction specialist. I've been working in Cincinnati for over a decade dealing with what feels like and is most likely statistically ground zero insofar as the opioid crisis. So I imagine that's why I was asked to come and speak today. I also spend most of my time crosswalking what's most important for patients insofar as the care delivered, as well as how to get paid to do it. So I guess that's exactly why I was brought. Next slide, please. I was very fortunate to present the Surgeon General's plan with him in Los Angeles several months ago, and I remind everyone of this statement that you can read, and I will not read it for you, but if you pay attention to the bold sections, we already talked about how many people we're dealing with. I think that a lot of the public health publications over the past few months have said we were probably underreporting that in some areas by as much as 100%, which is quite frightening, particularly in the Midwest where I practice. And that the fact that it is similar to all levels of diabetes and cancer combined is also something we ought to pay attention to, because I have asked for, and have not received it from anyone yet, a crosswalk of the reimbursement in comparison from diabetes to cancer versus addiction. I would propose it is probably not equivalent. Dr. Murthy said the same thing. Don't invest nearly the same amount of attention or resources, and that this has to change. Again, speaking after the prestigious panel before us, I think they said a lot of these things. I think that it is now time to make the change. Next slide, please. Brief agenda. I, by the way, was given about 10 minutes to cover substance use disorder, so I'm going to do my very best. So the issue, the disease model, and the treatment model. Please proceed. These are statistics that I don't necessarily need to read to you all. We know that this is impacting our country substantially, both from a health status as well as financially. I think I do a lot of work on the financial side. I actually was a business major and then went back to do my MBA during residency, which was a terrible idea, by the way, to do them concomitantly. But the fact of the matter is this is crushing our economy. I think that, I'm excited to see that our economy has picked up over the past several years, but in the region where I am, we literally can't employ people. As many as 1 in 3 people can't pass a drug test. We have major employers in Cincinnati like Procter & Gamble and Kroger's and places that are coming to me to find answers to how they can employ or treat people after they're employed, which was not a conversation I thought I'd be having after 5 or 10 years ago. Next slide, please. Oh, thank you. It is no surprise to anyone that we consume more opioids than any other country in the world, and by quite a bit. I define our practice, although we are a state-certified alcohol and drug treatment program with multiple sites throughout the Southwest Ohio, what we really are is a polypharmacy reduction agency. So every day I go to work and I try to talk people off of either medications they're prescribed, probably inappropriately, or things they're buying on the street. And so that is my job at work when I see patients at Brightview. These are, impactful and concerning slides that I'm sure many of you have seen before in relation to the opioid crisis. There was a New York Times article more recently, which I was not able to put into this presentation, that demonstrated what I'd call what most mathematicians call a quadratic curve upwards. The last thing you ever want to say are quadratic curve and mortality in the same sentence. But that is what we are dealing with. We are seeing a uptick in opioid mortality that is nearly straight up at this point, and it is obviously, honestly very frightening. I'm going to talk a little bit more about a paper we'll be releasing in partnership between ASAM and AMA in a minute. But one of the individuals that's working on that committee often asks me why I preemptively describe the disease of substance use disorder. Why do you always give a preamble, Dr. Ryan, in every presentation? He said, don't we all agree that it's a disease? And I said, I don't know who we is. I agree, I'm sure he agrees, most of the people in this audience agree. but I lecture to a lot of medical professionals around the country, and I will not say that we agree on that. It fits the definition of the disease, and it is fatal without treatment almost uniformly. We have to define that. We have to convince people of that, not just the public. We think they're not in line with this theory, but in all honesty, the medical community is not in line with this theory, and that is a very big problem. Good news is it's not Dr. Ryan's theory, it's everybody's theory. So ASAM, NIDA, SAMHSA, Surgeon General, APA, the Veterans Affairs have all released this definition simultaneously, basically, and have published papers and forums on things to say that this is a biopsychosocial disease and we must treat it as such. And it's chronic and relapsing. We have to engage the treatment continuum in that way, because I'm here to tell you what we're currently doing is not working, specifically things like short-term residential, which once you understand the chronic disease model, wouldn't make sense to anybody in the first place, unless you're getting paid quite well to do it. Treatment is a critical part of the total solution of the opioid crisis, and again, substance use more broadly. I don't want to make light of the fact that we have an increasing problem with other prescription misuse of many psychoactive drugs, and alcoholism is on the way up. And so we need to understand that treatment is a critical part of the solution, but not the only. It is obviously very complicated and multifactorial. I am proud to be representing ASAM today and talking about this issue, because I think they've done a wonderful job over the past few years in trying to define this continuum and talk about how you engage people in treatment and how you put them in the right place the first time. And that's why they have published the ASAM criteria, and we're seeing that it is getting broadly distributed and sometimes required by law for utilization, for people to be assessed with evidence and put into the right level of care the first time. My organization and I in Cincinnati have spent almost 5 years at this point, to a point that was made earlier, trying to smash together the silos of medical, psychological, and social reimbursement to make a model work. This is what we do every day, but I am sad to say that it is very unique that we've been able to pull that off. And our CFO, who is a generally reasonable guy, but is a CPA by nature, and he spends a fair bit of his time arguing with payers every day, saying, I can't deal with that silo. I have to get this payment from that section. I have to get this payment. You can imagine when we're calling contractors and saying, I need the full boat, medical, psychological, and social reimbursement structure in order to deliver appropriate treatment to this patient. I think he spends 80% of his time doing it, and I spend a fair bit as well. We have to understand that's the treatment model and subsequently align the reimbursement with that. I was just speaking to this, but I think it's probably the most important point I'm going to convey today, and I won't take much more of your time. When I was asked by the AMA and a few others to consider putting a paper together on alternative payment models, I've done work before with Medicaid and Medicare on alternative payment models for asthma, knee replacement, other things, as an emergency physician years ago when all of that talk started. What my biggest problem was I said, I don't think we have a model of care or reimbursement today. How are we going to jump beyond that to a new one? And I still don't have a great answer to that, by the way, and I think it's already been relayed by the panel this morning before us. All of these things live in silos, and they have to come together. It is impossible for me as a clinician to see a patient and say, hey, I think you really need X support, Y service, see this psychologist, PTSD therapy, but I have no idea how we're going to find that person, get it paid for, deliver the service in any way, shape, or form. If we achieve anything through work with the CMMI, through this conference, this is my hope, is that we understand the medical, psychological, and social treatment model for a chronic, relapsing biopsychosocial disease, and that we develop payment models to do so. And as previously alluded to, I'm happy to say that within the next several weeks, the AMA and ASAM, myself, and our committee at Payer Relations will be releasing a white paper on the subject in an attempt to move the needle forward, despite my reservations of not having a current model to go from, but to move the needle forward in an attempt to jump where we need to go right now, because we have to do something different today. Thank you.
Thank you so much. Now let's welcome Dr. Tammy Mark, who's going to be talking about the payment perspective.
Thanks so much. It's really exciting to be part of this summit. I was asked to talk about the payment perspective, and in particular to address 3 questions. How are substance use disorders typically covered? How does substance use disorder coverage affect outcomes, and what are some of the coverage challenges? So I'll be talking a million miles a minute to cover all of that. But actually, I'll try to do a very broad brush overview and hopefully leave you with some food for thought on these three challenging but important questions. So a first key take-home message is over the last 3 to 5 years, because of the ACA, we've seen tremendous expansion in insurance for people with substance use disorders. This is data from the SAMHSA National Survey of Drug Use and Health. In the blue, you can see the 2015 data. In the yellow, it's 2012. So with individuals with substance use disorder, their rate of being uninsured dropped from 24% to 16% in just 3 years. So that's tremendous progress in providing access to insurance. A related key take-home message is that because of the essential health benefit requirements of the ACA and the Mental Health Parity and Addictions Equity Act, or MAPIA, not only do more people with substance use disorders have insurance, but they have insurance that includes coverage for SUD services, and they have coverage with less limits. So if we look at employer surveys from 2006, they showed that 64% of plans had limits annually on the number of SUD hospital patient days. 65% had limits on the average number of substance use disorder office visits that one could have. 3 different studies using 3 different methodologies and data sets found that by 2015, those limits were essentially eliminated. No plans had limits anymore. So while MAPIA requires that the mental health and substance use disorder services be provided no more stringently than medical surgical services, they don't actually require that the services be provided at all. So this is recent data that MACPAC put together on coverage of SUD services under Medicaid. Some surprising things for me is how many states and DC don't still cover effective and important services like intensive outpatient, psychotherapy, medically monitored detox. Still significant coverage gaps. This is data on Medicaid coverage of addiction medications. Key take home here is that 20 states still don't cover methadone under Medicaid, a life-saving medication for opioid use disorders. So then the second question, how does SUD coverage affect outcomes? We know from a mountain of evidence that when people gain insurance, they're protected financially from the high cost of addiction services. We also know from decades of research that insurance improves access, so we can put check marks on those first 2 outcomes of the effect of insurance coverage. We know, as was stated earlier, that there are many effective interventions for substance use disorder: methadone, buprenorphine, cognitive behavioral therapy, contingency management, motivational interviewing. So to the extent that insurance improves access, and we know that it does, insurance coverage will also improve health outcomes. Finally, in terms of reduced costs, it's interesting that we only ask behavioral health services to not just improve health outcomes, but also to reduce costs. We don't ask that of cancer treatment, for example. But it turns out for substance use disorders, they actually do reduce costs. Published studies done from Washington State, where they expanded Medicaid coverage of substance use disorder treatment and then subsequently took it away, showed that costs went down when they expanded coverage. More recent studies done in Vermont showed that when they expanded coverage of MAT, medication-assisted therapy, they saw a decline in costs. So we can put a check mark there. Finally, in terms of population or system-level health outcomes, I'm putting a question mark here just because I don't think we have good ways to monitor this, similar to most diseases and most treatments. We don't have a good way to monitor the effect of treatment at a population level. And we know that even though there are many effective treatments out there, most people aren't getting the effective treatments. And we know that once treatments diffuse widely, they can sometimes have unintended consequences. So until we really have a good way to monitor this, I think we should be cautious about interpreting what the effect of insurance coverage will be on the population level outcomes. Okay, so the third question I was asked to address is what are some of the challenges? And so, yeah, there are a lot of challenges. But I think kind of the essential point here is we have the same challenge in substance use disorders that we have in all kinds of medical care. And that is, how do we incentivize the delivery of effective treatment? And the tools that we have are very similar to many of the tools that we have in other areas of medicine. One tool that I want to highlight is measurement-based care. This is the systematic administration of symptom rating scales to drive clinical decision-making at the level of the individual patient. So here's an example of 2 questions that I've taken out of a 17-question scale called the Brief Addiction Monitoring Scale. And you can see in this example, one of the questions is, in the past 30 or 7 days, how many days have you felt depressed, anxious, angry, or very upset throughout most of the day? And this patient is clearly improving. By week 8, they're seeing a decline in their symptoms. The second question asks, how many days in the past 30 or 7 did you drink alcohol? And again, we're seeing improvement. But if that patient was not improving, or if that patient was deteriorating, this is a warning system, so the patient and the clinician can sit down together and say, okay, what can we do to change the treatment protocol so we can address your static or deteriorating symptoms? Similarly, at the population level, we need better population level reporting. And this is an example from Vermont, which has really been innovative in looking at population statistics and putting them up for the public to see. Similarly, we need better tools to help consumers select addiction treatment providers, similar to the tools that CMS has developed for nursing homes, hospitals, physicians, and health homes in their COMPARE programs. I would argue that the addiction industry is where the nursing home industry was in the 1980s. The 1980s, concerned about substandard care led to the passage of OBRA 87, which established minimum requirements for nursing homes eligible to receive Medicare and Medicaid payment, and put in place enforcement systems and also patient assessment methodologies. That eventually led to the STARS program. The slide shows you a picture of a STARS program COMPARE. And you can go online and see very simply, where do you want to put your, where would you like to go, or where would you want to put your loved one? We need something like that for the addiction industry, for the addiction facilities. And probably because traditionally, substance use disorders have not been covered under Medicare and Medicaid. CMS has really not developed a robust accountability and quality infrastructure for substance use disorder facilities. However, the states have been taking the lead in this effort, in part driven by the SAMHSA block grant requirements, and because of the fact that they're the main payer, or historically have been the main payer for substance use disorders. So this slide shows what Connecticut has been doing. They've been taking the substance use disorder data, aggregating it by provider, and then putting it on their website. So providers can see, how am I doing in terms of getting my patients to complete treatment successfully? Am I following up with my patients in 30 days? Why am I doing a little bit worse than my neighbor? And this can drive improvement within the system. Another challenge that was called out in the recent Surgeon General's report, Facing Addiction, is expanding and integrating addiction into traditional medical settings and expanding the number of physicians, as Patrick Kennedy mentioned, willing and able to treat addictions. And this slide shows trends in physician office visits for SUD and for buprenorphine. We can see that since 2007, when buprenorphine first was marketed, around 2008, there's been an increase, but we know there's still not nearly enough physicians willing and trained to treat addiction out there. One barrier to getting more physicians interested in addiction is a hassle of dealing with prior authorization for third-party payers. Prior auth and utilization review is also of great concern to patients, particularly as these quantitative limits have declined. On the other hand, we know that UR can be an important tool for ensuring appropriate use of healthcare services. So what I would argue is we need more research and evaluation on how best to use this tool. So go back to that. So what this slide shows you is it's a little, the data is a little old, but it shows you, it's from 2011 to 2013. It shows you what percentage of states in the DC had prior auth on SUD medications. You can see almost every state had prior auth on Suboxone. A lot of states are now starting to remove that because we now know that getting people in treatment for opioid use disorders quickly is essential. So the final challenge that I'd like to highlight is coordination and reimbursement across settings and specialties, and reimbursement for services that fall outside of traditional insurance coverage, such as peer support, housing, employment supports, and prevention. We know that prevention and early intervention are more cost-effective than treating addiction, and that our current health insurance system doesn't have good ways to pay for it or encourage it. We know that housing, employment, social supports are important aspects of recovery and are also traditionally excluded from the insurance model. So one place to look to where there have made some advances in this regard is Vermont in the hub and spoke model, where they're providing supports for community physicians and integrating social services. A number of states are starting to pursue this model through their STR grants and other mechanisms. So that was a whirlwind tour through very complex questions. Hopefully give you some food for thought, and then a lot of references at the end if you want to dig into this further.
Thank you so much, Dr. Mark. And now we will hear from Mr. Carlos Hardy about the community perspective. Thank you.
Good morning. Before I get started, I'd just like to send brief prayers to our friends in Houston and those on the East Coast in Florida and Georgia that are about to experience probably one of the worst hurricanes, and also our friends in Mexico that they just had a earthquake 8.5 on the Richter scale. And I think about all those folks that are accessing services, that are attending meetings, that are going to have that disrupted, and I pray for them. I'd also like to thank Alex and the CMS team for the invitation to be here today. I felt like when I got the invitation that I was the outlier, you know, because when we first started, it was like, we want you to give the state perspective. I was like, oh, no, I cannot talk for the state of Maryland. But what I can do, Tom, is I can share my experience, strength, and hope. And I'm really glad to see my friend Tom Coderre. I just saw Carol McDade from McShin Foundation, and those folks are my family. And I'm big on relationships. So some of the more seasoned folks in the room might remember this guy, Paul Harvey. Paul used to come on the radio on this daily thing, and he used to talk about these obscure facts or historical events or people, and his byline was, and now you know the rest of the story. And I used to love listening to him, all right? So here's my rest of the story. I'm the oldest of 8 kids. I was born in Baltimore. I've been a homeowner for the last 20 years. I returned to school at 48 to get my master's in human services. Thanks to the miracle of modern pharmacology time, I'm a first-time dad at the age of 51. Okay? So I'm the proud dad of a 10-year-old, soon to be 11. Let's not get that twisted. He'll be 11 in January. A 5th grader, Antonio Hardy. And so as much as I want to deny it also, I'm getting old, y'all. I'll be 62 in October. So, but there's an upside. On the 23rd of this month, I'll celebrate my 24th year in long-term recovery. And in April 2009, I lost my baby brother, Robert Hardy, to this disease. He OD'd in the basement of a house that we grew up in that my parents still owned. And so there's no question about what my motivation is for doing this work. I have a young son, his mother and I, well, he's predisposed because of his mother and I. I've lost family members to this, and I'm motivated each and every day to see what we can do about improving this current system that we have, especially as it relates to recovery. So this is my organization, and I started it in like 2012. And this was after almost 18 years of working in various management positions. I just felt like I could do it a little better. And a lot of that had to do with Tom, and a lot of that had to do with Faces and Voices of Recovery. A lot of that had to do with my introduction to recovery community organizations and the organized recovery community. I got motivated and I got fired up. One of the things, and this is, it talks about recovery community organizations, and this is basically from SAMHSA. And one of the things I like is it talks about our constituents. Those in long-term recovery, those are accessing recovery, their families, friends, and allies. Because we are a constituency, whether you believe it or not. When I formed my organization, a lot of it had to do with a meeting that I had with a gentleman that runs a local foundation here, Don Knott and the Knott Foundation. And Mr. Knott basically said is that his foundation was looking at funding and supporting organizations that had this vertical integration model sort of like in place. And all that is a one-stop shop. So my thought was, how do I create this one-stop shop in this new world order, if you will? So what does the new world order look like in Baltimore, Maryland? Well, say the last 10 years, 12 years, there was expansion of primary adult care and Medicaid services. There was the rollout of behavioral health care integration in Maryland and the tensions between mental health providers and substance abuse providers when this happened. There was the declaration of the opioid abuse as an epidemic in Maryland, and more importantly, how this played out in communities of color where the question was, oh, now it's an epidemic. There was the expansion of Medicaid-assisted treatment as a preferred treatment modality. There's even stigma within the MAT recipient community. It's like if I'm on a certain type of medication, I'm better than you. So methadone is the like cross and bones, but yet buprenorphine and Vivitrol are a little bit better. Legalization of marijuana. All right, but yet the treatment community comes out against it, even though it's a prescribed medication. We're looking at safe injection facilities here in Maryland. We're opening a stabilization center soon, but they won't allow walk-ins. The expansion of needle exchange here, funding and expansion of recovery services, especially housing and supportive employment. So when I started looking at this, what is recovery's role in this new world order? I went to Lincoln University and I had systems theory hammered into me. And I began to form this opinion and this belief that recovery time is actually a macro system. Even though oftentimes we're treated and thought of and approached as a micro or as an adjunct to some other system, in essence, I believe that we are a macro system. And so my mission in life has been to advocate for that. I have a background as a community organizer, and so sometimes, and Tom can probably appreciate this, I have a foot in the advocacy world, I have a foot in the activism world, and the community's organizer's mantra is to agitate but not alienate. And so what does that mean? Well, we have the ever-present NIMBY, or Not in My Backyard issues. You had the recovery community going down to Annapolis every year, advocating in support of the treatment budget. But yet you have treatment providers that will sit in front of a legislative body and say, we think recovery is a good thing, but if you reallocate treatment dollars to recovery, then in essence it's a waste of dollars. But yet they want our support. You know, we passed the alcohol tax bill in 2010, and in 2011 we saw the first funding earmarked specifically for recovery services, $6.5 million. When Senators Wellstone and Domenici first introduced their parity legislation in 2008, it was simply known as Mental Health Parity Act. The recovery community organized and galvanized and fought real hard to get the term addiction equity added in that bill. When the Comprehensive Addiction and Recovery Act passed, we've had to fight to make sure recovery language and funding for recovery is included in that bill. This saying, I tried to research it and find out where it came from, but it says, my path is mine alone, but I cannot path alone. And I understand is that I can't do this work in a bubble. Not only do I need to galvanize my constituents, which are people in recovery, family members impacted, those that are struggling with addiction, I need to find out how to work with others, CMS, more traditional systems, the legislature. And that's what we've been focusing on, is that treatment has a message. I believe it's effective. I believe, oh, that's my part, my fault. I went too far on the scales. So my mantra is recovery voices count. We are here. We're not going anywhere. We're your best friends. I believe that treatment is a true macro system. And I'll just close with this. So last night, I went to a 12-step meeting, and there was a friend that was celebrating 34 years in recovery. The first 8 people that he called up probably combined had over 500 years of recovery. If you looked at everybody in the room, because I've been around for a while, there was well over 3,000 years of recovery. And I think as a system, we haven't realized and figured out how we leverage this asset. And I think what it's going to call for is changes in how we pay and deliver care, and that we can no longer think of recovery as just an adjunct, and that we begin to fund recovery community organizations, and that we begin to fund recovery services, including housing and employment development. So I'll end with that and jump off my soapbox. Thank you.
So we actually have quite a bit of time for questions, which is great. We do want to hear from you. So there are runners, right? Runners and microphones. Encourage you to ask questions. This is where we want to listen to what you have to say and get great ideas on how we can partner with you to hopefully solve, at least start to tackle this problem and indeed solve it. But I'm quite verbose, so I can start. I am as I said, the Deputy Director of the State Innovations Group. And our mission, we are testing the ability of state governments to use their policy and regulatory levers to accelerate healthcare transformation efforts in their states. So it's really about building infrastructure and the supports to make it all happen. So getting to the macro level, if I may steal from you. And actually, way back when, and Claire Roble, our former fabulous member of the State Innovations Group, remembers when David Blumenthal got up on a similar stage and said, it's really about developing the macro systems so the microsystems can flourish. So we are aligned. All right. So, and Dr. Mark, you mentioned the state of Vermont. We actually, my group works very closely with the state of Vermont. We have an agreement with the state of Vermont to have a all-payer model that is actually going to be accountable for their rates of substance use, deaths from substance use and suicide. So we are starting to measure outcomes as opposed to process measures. So that's the kind of work we do, and we want to hear more about, again, what the states can do to help. So that's kind of my question, but I see that we do have a question, and it's not all about me. I want to hear from you. So please introduce yourself and ask your question. Thank you.
Hi there, Nathaniel Counts, Mental Health America. And I'm going to ask 2 leading questions, but I didn't collude with you in advance, so we'll see how they go. The first one is, what is the role of incentives on primary care or at the ACO level in promoting effective treatment and follow-up? And then the second one is, assuming that maybe there's a problem beyond just linking all of the services, like that might not get us to the solution, because there's a certain milieu in which all of this happens. And so when you have like the linked services systems or community recovery organizations or accountable health communities, what do you do when that doesn't meet all of the needs? Like, would there be a use for like a wellness trust, for example, or something like that that allows you to meet needs when there is no there?
I guess I'll start with question number 1. We're working through in the state of Ohio a multitude of barriers to getting physicians engaged in treating substance use and mental health, including getting their federal data waiver to do medication-assisted treatment prescribing. There's been a fair number of papers about what the barriers are, but I'll break them down fairly simply, at least one that I think is preventing a lot of physicians. There is some fear. of the medications, the misunderstanding. We didn't learn any of this in medical school. I didn't. I'm happy to say we have medical education and residency programs going on in Ohio now and across the country through SAMHSA and COPE, COPE, but we didn't learn this stuff, so there's some fear of the medications, the understanding. There's also just the fear of taking care of the patients. Let's see, Wednesday of this week, I had a patient come in at 5:45, completely off of all of her medications, including her psychiatric medications. You can imagine I did not leave that appointment for quite some time. And so when you're trying to engage primary care physicians or other physicians who have historically not taken care of mental health and addiction and convince them to do this, to spend time doing something they weren't trained to do, to spend time dealing with challenging patients and situations, and then they get reimbursed at an E&M code for a 99213 or 4, like $80, you might imagine why I don't get very far with that conversation. And so I think it was stated very early on, we have to incentivize financially providers of all types, not just physicians, to engage with challenging populations and manage those diseases so that we can save money later. Because I promise, and by the way, this patient did repeatedly tell me she was going to go to the ED because of some skin thing she had going on, which was not present. I think I convinced her not to go, which would have saved Medicaid $2,300. And so that is, I think it was worth it. But if we hadn't worked at our organization so long to get a comprehensive reimbursement structure, smashing those silos together, I would have basically gotten paid $40 to try to talk her out of going to the ED. So, I can't support enough the discussion about moving the reimbursement structure forward in order to appropriately incentivize, again, all providers, including psychologists, recovery providers, to get engaged in this disease state and treat it. The second question was quite long, as was my answer, so I apologize. I don't have an answer to that one.
I can just tag on to your point. I think, fee-for-service is not going to do it in terms of integrating. One model that's been really interesting to see start to get on the ground is the Certified Community Behavioral Health Center demo, where they're talking to some of the clinics preliminarily. They're telling us that they're able to do this kind of integration because they're not being paid fee-for-service, so they can have someone come on and do the smoking cessation, which is probably going to kill their patients before their SMI is. So looking outside that fee-for-service or is not going to help, put it that way. So, yeah.
And one final point on that is integration. What we were able to do in our practice is I can deal with that patient's issues as much as I can, but when she starts to go outside the boundaries of issues I can handle, to connect to her recovery support, to connect to her psychologist, to connect to her case manager, we have a HIPAA-compliant messaging platform in Cincinnati called DocHalo, which I can instantaneously message her other treatment providers and say, hey, this is outside of the bounds of what I'm can do for this patient. I need you all to jump in and help me. And it's only because of our integrated payment structure, which has basically just been a hybridization of, there's no definitive structure to what we're doing in our organization, but it's allowed me to do things like that, which are critical.
And I'm a big supporter of fee-for-service. Right now, recovery support services in Maryland are funded primarily through funding that comes from SAMHSA to the states, and they give it to the local treatment programs. Mm-hmm. I would really like to see peer recovery support services reimbursable under Medicaid. I also believe that we need an incentive-based system because even within the recovery community, we have a lot of stigma and discrimination, particularly around recovery housing or supportive housing and the resistance from the housing providers to offer housing to anybody, especially on MAT, seems to be a big problem. And so there's a carrot and stick approach, and I believe incentivizing might move that stick forward, so to speak.
Okay.
Sorry, also vertically challenged here.
Yes.
Danielle Lloyd with Premier Healthcare Alliance. We're an alliance of about 3,600 hospitals nationwide and 120,000 alternate sites, physician groups, et cetera. And we run some very large-scale bundled payment and ACO collaboratives. And one thing I'm a bit surprised didn't really come up much in this panel or even in the opening remarks was something called 42 CFR Part 2. I think everybody who knows in the world what that is probably sitting in this room right now. For those of you who don't, it's a 1970s law that puts major constraints on providers in sharing substance use data with each other, something we've really struggled with in our population health efforts. So I thought that might be something that you, particularly Sean, maybe could comment on and struggles with that.
Sure. So absolutely, it's a problem, and I like to give examples because I think it brings real world, discussion. So when a nurse refers, we're trying to do healthcare integration in Cincinnati. We've got all 5 health systems engaged there, and when a nurse is willing to refer a patient to us to get substance use disorder treatment post discharge, and then they call back to see if they showed up, and I can't tell them, they're not real happy, right? They're like, but I made the effort. Yeah, I know, but I'm sorry, I don't know if he or she is here, which is a lie. And so I think there was a recent renovation from CFR 42 Part 2, but I think most people that have evaluated, all of our legal team has looked at it and said, we don't think it's gone far enough. We actually are working with Apris Healthcare as of yesterday, which does a lot of the PDMP work around the country. NarxCheck is our NarxCare is their product. They're looking at building a treatment capacity platform. First question out of the bat, well, how do we deal with the compliance with CFR 42 Part 2 for referrals back and forth? So I would hope and support and work with anyone, federal agency who is willing to, again, further renovate CFR 42 Part 2 to allow more meaningful and transparent communication.
It's actually even an issue within the recovery arena. So you'll have folks that are living in recovery residences that might still be engaged with treatment. And it would be beneficial to be able to have the recovery program talk to the treatment program, or at least coordinate. And we thought something as simple as signing consent to release form would be enough. But there's resistance within the treatment community to even communicate with the recovery community. And we need to figure out how we bridge that, because it's all about applying a holistic approach. So it would be helpful if we could figure it out.
Good morning. My name's Tom Coderre, and I served in the previous administration at the Substance Abuse and Mental Health Service Administration. I'm currently at Alterum. Alterum is a national nonprofit whose mission is to design and implement bold solutions that elevate the health and healthcare of all Americans. We submitted some testimony to CMS, so our recommendations are there. But I had just a couple points I wanted to make. First, thank you, Carlos, for getting up today and really sharing the hope that is recovery and your personal story. Very, very meaningful. As a person in long-term recovery myself, I really appreciate that. Thank you for doing that. Secondly, in the slides that were shared, we heard that this is a chronic relapsing brain disease. We keep hearing that. And I really believe that language is important. And so I think we need to find more hopeful words to talk about that. And the Surgeon General's report gave us some guidance, because it calls it a chronic brain disease, but it says that it has the potential for both recovery and reoccurrence. And I think that's a better way to state it. It's a little bit more hopeful, so hopefully we can start talking about it that way, so that people really make recovery the outcome. Because I think we've all accepted the thought that we can't arrest our way out of this problem. Well, we can't treat our way out of it either. We need to recover our way out of it. So for people to have hopeful language, I think, is critically important. One of the things that Alterum recommended in its testimony is that we move to a care coordination model. And we talk about every program having clearly defined outcomes. We propose the delivery systems and payment reform models involving these populations, that the outcomes should be stable recovery and lower severity adjusted per capita costs of care. And we talk about having care coordinators helping from the very beginning, when clients first start, when they first present and are first identified to have a disorder, that they are paired with a care coordinator. I'd like to get the impressions of the panelists about how they feel about that model, and if they've seen that working in other places, and if that should be more widely adopted.
I'll speak from a group that has care coordinators, or we call them all manner of things, care coordinators, case managers, social workers. They're all, in our group, very similar in line. And I'll tell you, I probably couldn't do my job without them. I guess that's a profound support of what you're describing. And I will tell you that my previous life was doing a lot of skilled nursing facility, continuum care work for Mercy Health in Ohio. And in the same vein, in that chronic disease situation, we were very dependent on someone basically holding the bag, right? Which is often the care coordinator who can help. The rest of us are trying to engage intermittently with that patient and make sure that their care plan is consistent across the continuum. It's very important.
So yeah, I'm a big believer in care coordination. My company actually did care coordination for the state of Maryland for about 18 months. We just wrapped up a 3-year contract with the state of Maryland to organize recovery residences as a membership association. So we ended up with 92 providers in 17 of 24 Maryland jurisdictions. They're operating about 220 facilities, providing close to 2,200 beds. And so when we were running on all cylinders time, we were providing care coordination services to about 350 folks. One is, it's how are you going to pay for care coordination services? All right, so somebody has to provide it. That was a big issue. Maryland put their money into their administrative service organization, which made them the payee, so we were actually billing Medicaid for it. So we could get a specific dollar amount for an assessment, and then we were able to charge a surcharge like $5 or something like that. But care coordination was awesome, man. We in addition to paying for housing, we bought teeth, we bought glasses, we paid folks to go back for phlebotomy school. It was just really, really awesome. The issue with it is the more folks that come in recovery, the more folks that access it, the less dollars that you have available. So in its heyday, we saw maybe a $4,000 cap being applied to now a $2,500 cap. But it's critical for recovery initiation and sustainability.
Yeah, we can't be throwing good money after bad, right? We have to be making sure that we wrap those services around people so that they are not just have help navigating the complex medical things that they're doing, but navigating the systems outside of the medical care that are going to keep them in recovery. Thanks.
Good morning, I'm Debbie Cagle, and I'm representing Centerstone. Centerstone is one of the leading providers in behavioral health services. We treat around 250,000 people a year in our 5 states, Tennessee, Indiana, Illinois, Kentucky, and Florida. We have seen the good work of evidence-based practices, and we're very happy to be here today to provide comment and to participate. And we want to thank the Innovation Center for the ability to come and participate today, and thank you for your remarks.
Thank you.
We agree that federal funding should be effectively leveraged and targeted in order to combat the opioid crisis. And it's especially true for those individuals who have co-occurring addiction, mental health disorders, and combined with physical health disorders, we believe that all should come together. And that's what we're doing at Centerstone. In an effort to combat the crisis, a couple of years ago, we decided that people seeking care should not get just what's behind the door where they present. So we developed an evidence-based addictions model that includes MAT, and we've seen the really great evidence. We've seen the great outcomes of applying the evidence-based model and doing rigorous monitoring. So today, our recommendations are, and I would love your comments, we strongly encourage tying federal dollars to evidence-based continuum of services. We would like to see the expansion of housing as part of the evidence-based continuum, especially certified recovery housing, providing safe and sober housing as a critical social determinant, encourages continued engagement in recovery and sustainability, which becomes possible when you have safe and secure services in a structured environment. I know this. I have a family member, 25 years old, 4 years in recovery. If it had not been for the full continuum and his ability to have the ongoing supports, he wouldn't be in college today working and have the return of his ability to think. And it took about 2 years as his brain returned to the ability to think and make judgments for himself and to live now a very healthy life. We would also encourage engaging high-risk consumers after an overdose. Today, we are not reimbursed in the field. We're not reimbursed when we have our staff go into an emergency room or as they're trying to engage and develop a plan with first responders in the field. So we need reimbursement for this important work that engages people to start into recovery. And we also endorse all the good work that's trying to be advanced for 42 CFR. Lastly, but we can go on and on. We would like to see programs that start at a really early age. In Anderson County, Tennessee, we have demonstrated that for every dollar spent on prevention in schools saves $18.38 in the community. We need to start and maintain evidence-based prevention curriculums. Again, I want to thank you, and I'd love a response to some of these ideas, and if anybody would like to review our current value-based contracts and some of the work that we're trying to do, or any of the outcomes that we've achieved, we'd be happy to share that at Centerstone. And thank you.
The only comment I would provide is that I think that especially when we're dealing with the most severe status of the illnesses that we are in the Midwest, that certified recovery housing can actually be a really big deal. My staff and I can do a wonderful job taking care of the patients, but if we can't find them an environment which is devoid of the people, places, and things, it is often quite a challenge and can drive our outcomes down. So yeah, I would absolutely support that.
I would just comment that the integration between behavioral health or mental health and substance use disorder is critical. I mean, it's so surprising to me how few mental health clinics are integrated, even how few psychiatrists treat substance use disorder. It just makes no sense. So completely agree with what Centerstone is doing.
Well, that one's a no-brainer for me. I'm a big supporter of housing. I want to thank SAMHSA for their ATR funding, because that's how Maryland began to subsidize, if you will, recovery residences. Now, we certified them, like I said, for 3 years, but I think it can't be just the housing. Housing is great, but it needs to be housing with the recovery support services. And that's the model we're trying to build. Where we're lacking is we don't have the evidence yet. We're working on it. We've got groups in Florida that are looking at recovery capital and some other things. But as we begin to build this body of science of the effectiveness of housing, I think we'll start seeing more of it.
My name is Brad Keys with SoberLink. We are a technology that remotely monitors alcohol use. Thank you to the panelists and everyone that put this on today. I have a real-world example of Dr. Ryan's quote, "Addiction is a chronic relapsing disease, but it's still primarily being treated acutely." It's what we have found. And we've been selling our product since 2011, when we've been embraced by hundreds of treatment facilities, and we're 100% self-pay. Payers, we have not had one conversation with a payer who is interested in reimbursing us for long-term care. Our product recently has been used in outpatient detox for 4 days, with success just in the last 6 months. And a very major payer reached out to us and wants to talk about reimbursing SoberLink for only 4 days. So it validates where all the payer money is going. But my question is to small technology companies like myself, the smartphone apps, the technologies that are changing lives. What could we do better to get in front of the payers, the states, and the people that make the change?
The good news, I think, to some extent in some states, is that the 21st Century Cures money includes some technological innovation focus. And so if I'm not a fan of grants solving everything by any stretch of the imagination, but when you're trying to get innovation off the ground, I would propose and support that you look to some states' technology funds who are focused on this issue. There are, as you stated, many applications, and we need to understand one point that was brought up earlier about care coordination. Technology can solve a lot of that. So I think it's an important point that we have to have a personal connection with each individual patient and treat them as an individual. However, we need to look to technology solutions to deal with the magnitude of this issue, or we will not solve it, I don't believe.
I can tell you, though, that we are working with SAMHSA and HRSA in the Integrated Center for Integrated Health Strategies on some telehealth initiatives to try and coordinate that work as well. So we're trying.
Hi, my name is Alice Demner, and I am with Community Catalyst. For those of you who don't know us, we're a national nonprofit advocacy group that works to empower consumers to be a strong voice in the health policy decisions across the country and in their communities, and lift up those voices in parallel with other stakeholders. So I wanted to thank the panel, particularly today, and the whole CMMI for, as one of our speakers just said, incorporating substance use disorders into this discussion. So often, behavioral health integration is about mental health and physical health with addiction sidelined. So that's really important to hear from the consumer perspective. All those things are connected. And it's great to talk about addressing social determinants, really building that into the system. Again, people aren't going to get well and stay well without that. I want to also lift up prevention. We haven't talked a lot about that, but that's a critical part. This is all being driven by the fact we have not, nowhere near enough prevention. We're not starting at a young enough age. We're not doing it. We're not talking to people about this. So Erwin urged folks to really think about and address that. And as an organization that represents consumer interests and brings the consumer voice out, I also want to urge and ask about how consumers and what consumers need and having them speak for themselves is really being incorporated into development of models, how consumers are being asked how things are working for them as part of the feedback, and how we're incorporating patient-reported outcomes when we're really beginning that more important focus on outcomes, and how can we speed up the development of those problems and get them used so that we're not relying on this other data that's either processed or not really relevant to people's lives and their recoveries.
I hate to keep speaking, but this is a really important point. One of the biggest problems we have in this country today is people do not know what to go get when they ask or looking for treatment. So SAMHSA has recently published, or not recently, has published some things. ASAM has a guide on what to look in for treatment. In our region, I was sitting with a healthcare system, and I said, well, you should probably ask some questions like, is there a medical provider involved? Do they answer the phone when you call? Sitting extraordinary, and one of the vice president of medical affairs said, well, that's a really low bar, Sean. I was like, yeah, I know, that's sad, but it's true. So I think consumer-driven advocacy in order to get the treatment industry to get in line with what the evidence is a huge issue. And that force will make a difference. If parents, patients, and the community members demand that the industry and the providers come to the table to provide evidence-based services, it'll happen. So by all means, that's a huge and important issue for the consumers to become educated and then to advocate for what they need for treatment.
Yeah, I would second that. It's sort of what I was trying to get at with the COMPARE programs. We have these wonderful COMPARE programs for all sorts of health services, but nothing for the addiction industry. So if you're a patient or a family member trying to find out what's the best service for myself or my family member, you have no idea where to go or what to look for. So that's a huge problem. I also agree in the addiction field, we haven't done enough research, we haven't collected enough data looking at patient perspectives. It's been a huge revolution in other areas of medicine, but if you look at the literature, there's very little literature looking at what did the consumer think about this. So it's a really important point. Thanks for raising it.
Thank you.
Hi, this is a wonderful conversation. My name's Mike Beyer, and I focus on how bipolar disorder fits into the dialogue of primary care mental health, and have filed lots of comments and appreciate how MACRA and all these other rules include discussions. But for this conversation on substance abuse, since bipolar disorder is such a co-occurring condition, I want to see if there's any type of encouragement that CMS can offer with how to get regulations expanded to include mental health symptoms that are specific related to substance abuse. And as an example, in New York, the regulations trying to tie into the federal CMS regs have a strong focus of only depression. So that would leave people with bipolar disorder who are harmed when treated just for depression potentially in an uncomfortable position. So I wanted to see how we could expand but not change a lot of the regulations to include a competency range for things like that, PTSD and anxiety. Thank you.
Yeah, I guess I'd start thinking about outcome-based quality measures. I mean, we're very good at measures that get people to do stuff, particularly measures that get people to prescribe medication, but you know, a lot of those antidepressants that we're learning can have negative side effects for people with bipolar, and we're not really tracking whether people are getting better for their depression or their bipolar. We're tracking whether they're prescribing over a certain period of time. So I think it's a really good point that you're raising.
Thank you.
And I also think the next panel is going to be talking about co-occurring conditions and other factors that contribute to those illnesses and effects. So I think, so stay tuned. Next, sir.
Bill Maroon from Resources for Human Development. I want to piggyback a little bit on Senator Stone's comments. We all know that, I'm sure everyone in this room knows that if someone doesn't have stable housing, they can't fully engage in treatment. But prior to that, I want to understand what CMS can do, what we can do as a community to encourage the development of safe injection sites. There's about 100, over 100 in every other country, or tons of countries around the world. There's none, to my knowledge, in the United States. I know Seattle's trying to move the needle on that. Boston has an observation site. But is there something that CMS can do to encourage the development of this, and what we can do as a community to encourage the development? And in Philadelphia alone, 900 people died of overdose last year. We're on pace to be around 1,300 this year. And that needle doesn't seem to be stopping in that direction. We need to turn it the other direction. Thanks.
I would say that I generally support, just this is a little bit of a personal opinion, generally support the safe injection site harm reduction strategies that are being discussed and propagated. But I ask that people think a little bit about something different. We do not have on-demand, appropriate, evidence-based access to treatment today. So the conversation is very challenging. We'd be here all day if we tried to solve that whole continuum you're discussing. But I would say that we need to focus as much, if not more, on making sure that when someone is ready to engage in treatment and recovery, that they have access that day or the next day. And I think we would be able to resolve a bunch of those issues. And I'm not saying that the safe injection sites and other harm reduction measures and needle exchanges are not important, because they are, because not everybody's ready to get into treatment. But we're missing, theoretically, we're treating 1 in 10 people, using the broad term treating, and another 2 out of that 10 are not able to access treatment when they actually go looking for it. So I know then there's obviously 7 out of 10 more that are potentially not ready to get into treatment at that time, but we're missing a huge segment who's looking for treatment and cannot find it when they are.
Okay, I think this can be our last question.
Great, thank you. I'll be respectful of time. Great panel, by the way. Good choices of people who have all contributed in so many important ways. I want to make a quick comment and then a question. And this comment probably won't make me very popular in this room, but I am a person whose medical information got inappropriately disclosed, my substance abuse treatment. I'm a person in long-term recovery, and so of course my experience informs the work I do both on policy and as the co-founder of a recovery community organization. The changes that occurred with me are really highbrow problems to have, but important ones for policy audiences like this to note. I could not get, when I wanted to start my own consulting firm, I couldn't get a health insurance policy. I could not get disability insurance. I could not get life insurance. And all of this was because my substance abuse treatment stays got redisclosed inappropriately. And so when we think about 42 CFR issues, I think one is a educational issue, because I think a lot of people misunderstand what the law actually does and doesn't do, and actually allows you to talk to more people than I think people realize. So that's one thing. I think the other thing, people in recovery, we do not leave our wounded on the battlefield. And increasingly, as overdoses have increased, what we have seen is more and more recipients, at least at our recovery community organization in Richmond, Virginia, people who have suffered near fatal overdoses, especially with fentanyl. We are seeing that they are coming back to us, and we take them with incredible memory problems that last for a good while, and also co-occurring medical problems like if they, laid on one of their limbs while they were overdosed for many hours without being found. They have compartment syndrome. They have tissue degeneration. They have organ problems. And right now, there does not seem to be a model of care where the medical, mental, and addiction services can be integrated together and meet people where they are in the community when they're being cared for. Because a lot of times people don't want to care for these people who can't remember appointments and that kind of thing. So really just with a bunch of really thought leaders in the audience to come up with models that can deal with what I think is going to be an increasing problem that we're going to see in communities.
I would encourage you to look at the Colorado State Innovation Model, how they integrate behavioral health. They have a whole way they try and co-locate and deal with these issues. It's very comprehensive.
Great.
Challenging.
We're doing the best we can at RCOs
Absolutely.
now, but we can certainly do
Absolutely.
better.
Lots of models out there. It is now 11:56. We did a great job. Thank you all for your questions and your attention. If your question was not answered, and or if you think of a new one, please email the address on the contact to that email address. Right? Okay. And we will get back to you as soon as we can. And I just want to take some time to thank our panel. It was really amazing. I learned a ton. And I will be following up with you to see if you can help our states as well. Thank you very much. So the next speaker. Oh, no, that's Chris does that. Oh, we're taking a break. Does everyone know where the bathrooms are? That way. Go out and take a right. Thank you. What do I do here?
Yeah. I know breaks are never, ever long enough. I'm so sorry. What time is it? All right. I think we're going to go ahead and get back underway here with our next panel. Since it's come up a few times, I think it would be worth maybe saying at a high level, Patrick talked a little bit about this. The Innovation Center can do a lot of things. There are a lot of things it can't do. But so as a convener is certainly something, right? Having the national conversation, as Fran alluded to, introducing the macro level infrastructure or encouraging it. Generally speaking, when we think of undertaking a model, for those who aren't necessarily as familiar with how our models work, we don't usually work it around a single application or a single technology. What we would do would be looking at changing, for example, how payment and delivery comprehensively are working for a very specific population. So I wanted to make sure folks understood that when we're listening to these conversations, we're really thinking about in that comprehensive way for us to move forward. It would never be one technology or one outcome measure or anything like that. It would be kind of very holistic. And although I don't know anything about how housing can happen through here, I was very encouraged by the conversation that we had in terms of thinking through those comprehensive pieces of treatment and delivery. So I wanted to next introduce Kirsten Baronio. She is a senior policy advisor on behavioral health care in our disabled and elderly health programs group in our Center for Medicaid. So I'm going to go ahead and have her come on up and do this next panel for us on mental health and co-occurring conditions.
Thanks, Chris. It's been really fun for me to see so many familiar faces this morning. And I'm very happy to help welcome our next panelists. First, we're going to hear from Dr. Verna Little, who is a Senior Vice President for Psychosocial Services and Community Affairs at the Institute for Family Health, which is one of the largest community health center networks in New York State. Then we're going to hear from Dr. Henry Harbin. Henry is a psychiatrist with over 40 years of experience in the behavioral health field, former CEO of Magellan, Director of Mental Health Authority for Maryland. He's now a healthcare consultant working with a number of organizations, including the Kennedy Forum, the Parity Implementation Coalition, and the University of Washington's Advanced Integrated Mental Health Solutions Center. Next, we're going to hear from Steve Barron, who is currently the Executive Director at the Maryland Behavioral Health Network, a network of community-based behavioral health providers. Steve was formerly the Director of the Department of Behavioral Health in DC for many years, and before that was head of the Baltimore City Mental Health Authority. And finally, we are going to hear from Joyce Roccanelli. She is a licensed clinical social worker for the Northwell Health System in New York, which is a large provider with a number of inpatient and outpatient facilities and programs, including a program she works on called that's a house calls program for homebound patients, where she facilitates access to care for individuals with complex conditions, including serious mental illness, and she has a lot of experience in advocacy for people with serious mental illnesses. And again, as with the prior panel, we will have an opportunity for questions and answers after we hear from our panelists. So please welcome to the podium, or actually, I think they're going to present from the table, Dr. Little.
Great. Thank you so much. I really appreciate the opportunity. And as someone who spends time in the weeds, as they say, working in an integrated care system, providing primary care, substance abuse, and behavioral health services, I think, what I'd like to really focus on is sort of what we've been paying attention to and what, sort of our work and what I hear from other people around the country that we're really trying to focus on and pay attention to and see opportunities to be able to have change and be able to move the needle some. So the first, really thinking about transitions of care and not thinking about it in the traditional sense that we'll talk about, but really thinking about it knowing that the people that we care for are at the greatest risk when they're experiencing a transition. And that can be a transition, we've sort of traditionally thought about it in terms of reimbursement from hospitals. And as we've been doing this work, really trying to think about it more thoughtfully and been thinking around it particularly from substance abuse treatment and from corrections, and have recently tried to work with local correctional facilities and thinking about what transitions would look like. And there's some standards in terms of same day, next day. And as we started to do that work, we actually were not successful with the few individuals we started with because they died by overdose in the first 24 hours. And so we started to think about what can we do differently and really pay attention to sort of what the requirements were for transitions of care and how could we apply that to other settings. And so I'd really like to put that out to you as something to think about. And the second is episodes of care, sort of a beginning, a middle, and an end, and really thinking about episodes, particularly around substance abuse care, depression care, and suicide care. And so traditionally, these are the codes that are out there that really cover what we would sort of narrowly define as a transition of care. And really, the ask is about broadening that and how can we redefine a transition, and also thinking about all of the components, that it really does take a village to have a good transition, and what does that look like? And so thinking about maybe not traditionally a prescriber, but being able to get connected to services. And is there the coordination that happens prior to the transition as well as after the transition? And so when we think about doing this, is there really the opportunity then for reimbursement around some of these other sort of not as defined transitions or not formally defined in terms of reimbursement? And so have been really thinking about this. And so when we think about concrete asks, I would think about transitions of care. And these are really difficult. When we think about transitions of care, we just talked about 42 CFR and some of the other pieces that come in around sharing information. And really thinking about if we had the opportunity to follow up with people, even from a hospitalization in a very different way, or if the transitions of care requirements were modified so that they would be more appropriate for other discharges other than a traditional hospital, even for a psychiatric admission. And so really thinking about what that might look like, and thinking about episodes. So we just had our friends from Centerstone stand up, and we have worked with them quite extensively around creating pathways for suicide care in the zero suicide work that we've been doing. And so thinking about what that would look like and how to be able to reimburse on the basis of those pathways in organizations of all types. And spending a lot of time around working with episodes of depression care, and the collaborative care codes have been an incredible addition, and the ability to move the needle forward around collaborative care and depression work, particularly the addition of the FQHCs. Thank you, CMS. However, really, when we looked at the depression episodes in organizations like ours and sort of what is a beginning, around a positive score, and then what is an ending around metrics, so really looking for that decrease, the 50% decrease. And when we looked at what that took to take somebody from the beginning to what we'll call an end or that outcome. What we really found in pulling that was that, again, it took a village, and that there were a lot of services in there that were not reimbursed, that were really critical to someone being able to sort of complete that episode of care. And really being able to look at that and try to rethink what that looks like. And so that was my very short but very concrete pitch to really rethink what some of those would look like.
You ready for me? Am I on? Can you hear me all right? Back there? All right. Thank you. I also want to add my thanks to CMS and CMMI both for their leadership in pulling this group together, also their leadership on moving forward with collaborative care. I'm starting with two slides, which I think quantify the first and I think most important priority for why would you change payment reforms or change anything, and that's to reduce the death rate. So this is a slide comparing common medical problems from 2004 to 2014 on the death rate decreases or increases, and as you can see, for other most common medical problems, we're getting progress. We're going the other way on suicide. When you go to the next slide, we see it goes literally off the chart. As you might imagine, that's opiate death rates. So it's over 200% as of that date. Unfortunately, as we know that since 2014, both suicide and opiate death rates have continued to increase at an even greater rate. So I show this one to say that's to me what our most important goal is of making changes in the healthcare system to improve behavioral health care. But also for another reason is that big organizations like CMS, all the insurers that are here, and large medical groups daily have to decide how to allocate resources between different disease groups. Whether people like to talk about not, there's a competition between do you invest in heart disease, cancer, mental health, brain, whatever. And so I'd just like to remind people that the mental health and substance abuse groups is losing out on the progress side. And that's great that we've made these gains on other healthcare problems, but I hope you would think about in terms of allocating more resources in the direction of the behavioral health death rates. This slide gets with one of the focuses of this is comorbidity. So this is a slide looking at the cost of common medical problems of those people with diabetes, heart disease that also have a behavioral health disorder. So as you can see from this, the increase in costs is somewhere between 250 to 350% if you just have diabetes without a behavioral health diagnosis or diabetes by itself. That's a huge escalator. We don't have a slide for the frequency with which people with chronic medical problems have a behavioral health disorder, both mental health and substance abuse. And that can range from 30% to 60% depending upon the particular diagnostic condition. So I would state that from a public health impact, we will never have a impact on total medical costs without investing better and more in the behavioral health arena. Because these are big contributors to the total health costs. Most of these increases, by the way, are on the medical, physical side, not on behavioral health delivery costs. One other comment about the death rate changes and what we're seeing is this has happened at a time in the greatest expansion of mental health and substance abuse coverage in the history of this country. More dollars, more people covered than ever. And yet we have a deterioration of our outcomes. So I would contend, while yes, there needs to be a debate about more money, I would say it's also equally important to look at where that money goes. So I've outlined sort of 3 general challenges, all of which could be assisted and improved by alternative payments or value-based payments. Some of those have been talked about by other people earlier. I'll try to just highlight a couple of these. I think one of the most important, it goes back to the prior thing on comorbid, is I don't think we're going to improve the effectiveness of outcomes if we don't improve the delivery of mental health care within the general medical system. So we know that in primary care, they treat more people with mental health substance abuse problems than the specialty mental health system. I think one statistic is only 20% of people with major depression will ever see a psychiatrist. So while they do more of the mild to moderate level of illnesses here, they also treat a lot of people with pretty severe illnesses. So given that most of the screening for behavioral health problems occurs in the general medical system, whether it's in the ERs, in a medical ward, or in primary care, we know that that screening is often inconsistent, doesn't use a standardized tool. We also know that many of the interventions delivered in primary care are suboptimal. The outcomes are not great. The consistency of delivering these things through evidence-based services is not very good. And they don't have the resources or the expertise that we know could be added that would improve their outcomes. Further, we also know there is a limited supply of psychiatrists and other mental health specialists. Even if we were to be successful in improving the in-network participation rate of mental health professionals, it will not allow full ability to treat everybody with these problems. So one of the key solutions is to improve what goes on in primary care. The collaborative care model is the most effective one we have. Thanks again to CMS for taking a leadership role and paying for this in Medicare. I think the most immediate thing that could happen that would improve care across the country would be for Medicaid agencies and all commercial insurers, many of whom in this room, to turn on the code. They don't need to do anything else. They can turn on that code. It already exists. They're all already paying, at least for the commercial carriers, they're paying for Medicare through the same codes. I don't think we'll ever see the full impact of collaborative care without all funders paying for it. If you're a primary care practice or a big medical practice, you're only getting one funder paying for it. It's a lot harder for you to switch and make the changes that you need to deliver this. So the second, and I was glad to see Tammy Marks and others mention measurement-based care. We find that primary care docs who are treating mental health substance abuse problems rarely use a quantifiable standardized instrument, and very few mental health professionals do. Even though it's interesting, primary care physicians and practitioners, they routinely use standardized quantifiable instruments when they treat common medical problems. You know, you would never treat hypertension without measuring the blood pressure every time they come. We do have tools for this, and they could be implemented today. I think this, when they were asked, the earlier panel was asked, what would you do today? I would say it would be this: to require that large medical systems as well as behavioral health specialists start using standardized quantifiable outcomes tools. And there is a group of advocates, some of them in the room, and major consumer groups who've written both CMS and AHIP, who jointly oversee this this voluntary consortium on core measures for ACOs and primary care medical homes. Currently, they only require a depression screen and a depression remission. That's it. I think we would urge them, and that's a standing request, that they add the measurement for other common mental health and substance abuse problems. I don't know how we're going to, if folks like this are screened and not tracked in where they enter the healthcare system, how would we ever have an impact on public health outcomes? The third general comment I want to make, again, this would be improved a lot with alternative payment mechanisms that was talked about earlier with some of the digital, is many of the treatments in our system are old. Doesn't mean they're bad, but we do know they don't reach a lot of people, even if done effectively. So most of the psychotropic drugs that we haven't really had hardly any new novel compounds for 3 decades. Psychosocial therapies, cognitive behavioral therapy was a standard in the field when I trained over 40 years ago. I hate to say how long ago that was, but so there are new and increasing technologies. Digital solutions offer a lot for our field in particular. So some of the new okay, I'm gonna run out of time. So let me shift to what are some of the recommendations, which include new technologies. I would say the first thing does not require a new alternative payment method. If you want to have some immediate changes, fully fund collaborative care, and fully fund and remove the barriers to telemental health. This would address a lot of the shortage issues to specialists because a consulting psychiatrist to a primary care practice can cover a lot more patients. These are some examples of collaborative, of proposed alternative payment things. I won't have time to go through them, but I'll list them. And I'll go to the last slide where you will be able to learn about this. The Scattergood Foundation has been funding a white paper. There's an interim copy that's being handed out today. Joe Pyle, who's the CEO of Scattergood, is over there, and it's being hosted on the Scattergood website. So this group has reached out to dozens of large medical providers, mental health providers. We have a list in the paper that you can see today of innovative alternative payment models that are going on today and some that are proposed. Our hope would be that all of those people here who have good ideas or want to propose them, to send them to Scattergood so that they could be incorporated in this paper. And I say that particularly to some of the insurers who I understand are doing some very innovative things. Some of them seem reluctant to share those. Some of them have shared them. We don't really want your payment codes and the way you're the rates that you're paying. We just want to know what bundles you're doing and what would you like to encourage the field to do more of. Thank you.
Thank you, Henry. Is it on? Yeah. Yeah, I'm Steve Barron, and I'm going to represent, I think, people who have been more deeper into on the mental health side than the primary care side. But just to flip what Henry said in terms of people, since the primary care practitioner is the primary deliverer of behavioral health services for so many people. For people who are very much engaged with our public mental health system, it's the public mental health providers who are much more knowledgeable and aware of the individual's needs and have the strongest relationship and engagement. However, our ability to pay attention to primary care needs is quite limited. So I'm going to talk about that, maybe hopefully make some recommendations. You go back to over a decade ago of these two major studies, the National Comorbidity Survey Replication and the NASHPIT State Mental Health Programs, which got a lot of attention in their time. And with the NASHPIT study in particular, found folks with serious mental illness were dying of non-behavioral health issues. So what are our challenges? Well, we have to ensure that comorbidities are addressed at the client level with a focus on the workflow challenges. That may just seem so obvious, but you look at structures that have the ability to work together, and we don't bring it down, the information and the coordination at the client level and at that practitioner level. So a lot with many of the practitioners, which you hear, feeling so overwhelmed that left on their own devices, these issues don't get attended to. So we need to ensure the staff have access to the medical data on the mental health side, have financing models that you've heard about all morning that incentivize this type of behavior and pay for the necessary activities. And there is a lot of changes, and I think we do need a lot of help in discerning what they are, but there are a lot of new technologies and how the behavioral health structure can take advantage of them. Well, just to kind of emphasize these areas to ensure that comorbidity is happening at the client level. And when I say delivery system, I mean any purchaser, because there's a lot of talk. A lot of the private insurers are much more aware that some of their high-cost users going in for medical emergency room use, preventable emergency rooms, preventable inpatient admissions, have untreated behavioral health disorders, even though they are showing up for their diabetes or other issues. So we need to make sure there's comprehensive assessments that take place at the behavioral health entities that capture the somatic information. There's immediate staff have access to the medical staff. The behavioral health treatment goals specify medical concerns, and that there's the training's there, there's the data is there, the payment methodology is there, And actually, as much as we don't like to talk about this, there needs to be some strong accountability and oversight and feedback to the providers to ensure they're doing what you're purchasing them to do. Well, I want to just be aware, there's so many different state structures to carve in, to carve out, to specialty MCOs, to services that are still in a very unmanaged fee-for-service. They all have their strengths and weaknesses in any structure. There's a lot to be built on for each. They don't necessarily, by the definition of their structure, define which system is better able to provide integrated care on the comorbid individuals with comorbidities. The devil's in the detail, and it's in the details in the contracts and the arrangements and the accountability that each has over their provider network. So I want to just briefly talk about two models that I'm familiar with. One, thanks to CMS and SAMHSA. I also want to thank CMS and the Innovation Center for doing this. This is a great kickoff. But building on the Chronic Health Homes Initiative, which was rolled out a couple years ago, and I think SAMHSA and a lot of advocates had really made sure mental health was at the table in the discussion, and folks with serious mental illness were considered one of the chronic health conditions that a state could address. Well, the model that I'm most familiar with now is in Maryland, and Maryland has developed a chronic health home initiative for people already connected to services in their system. But what that program has done, it pays for care coordination. The mental health providers have been able to hire medical staff, nursing staff, to work with the clients and the other staff. It's the only place, Maryland Public System serves about 200,000 people in their specialty system. These 6,000 or 7,000 folks are the only place that the behavioral health provider has access to the medical data and the behavioral health data, which is critical. So they are able, so the behavioral health home can then identify special initiatives on diabetes care, setting goals around A1C levels, hypertension, and a range of medical conditions that are talked about and are part of the culture of the Health Home Initiative. And that's so important. And out of that, we've been able to do a spin-off, a special initiative that identified people who have higher ED and inpatient utilizations. So I think there's a lot to be built on this health home model, and I know a number of states are participating, a number of states have done it differently, a number of states are serving more people, but hopefully we can learn from that and figure how that gets built into our structure. Oh, a little too fast. And the one project that you may not have seen that Henry mentioned in his was a program that's over 22 years in Baltimore City. It's a special case rate program for folks with serious mental illness. The criteria was that they had to be in a state hospital 6 months or more, or had 7 or more ED visits for psychiatric reasons over a 2-year period. There are providers who get a single rate that pays for it's a bundle rate for all their care. The Medicaid is part of the rate, but also Medicaid dollars only go to Medicaid covered services. Client's income is included, and that helps support the housing. There are well-defined outcomes, and the providers are monitored on their ability to deliver on these outcomes, which are housing, employment, quality of life, linkage to medical care, homelessness, and so on. And then the provider is entitled to some incentive payments. There's incentives and risks that are defined, that are assumed by the provider. And I think it's a platform, a model to think about expansion of a certain cohort of patients or individuals. And you also could involve some medical conditions. The rate would have to be adjusted. There have to be a study for that. But it has a strong financial structure, strong clinical expectations and outcomes. And I think you could translate that to some so involving the medical needs of the individuals. So, thank you.
Thank you. My name is Joyce Racanelli. I'm a social worker for the Northwell Health System, and currently I'm working as a Director of Ambulatory Care Management for the House Calls program. Carlos Hardy earlier said that he felt like an outlier. Well, believe me, right now I feel like an outlier as well. This is not my wheelhouse, but I am very passionate about what everybody has said today, and I think the House Calls program today is really making an effort to meet the needs of patients with severe and persistent mental illness, behavioral disorders, along with their co-occurring conditions. This is just some statistics around the Northwell Health System. It is one of the largest employers in New York. We currently have 22 hospitals and over 550 ambulatory and physician offices, post-acute services, and population health management. The House Calls program is a home-based primary care. We service over 1,200 debilitated homebound patients, mostly in Queens, Nassau, and Suffolk County of Long Island. My New York accent, I'm sorry. Just to continue, we serve our population complexion. We have many patients with multiple chronic medical and mental health and behavioral conditions, including a high prevalence of dementia. I know we're going to talk about dementia a little bit later on, but I did feel it important to single it out for a moment. The patients that we have being geriatric and with the high prevalence of dementia, about a third of them have behavioral disturbances as well. In addition to that, our population has about 36% of patients diagnosed with depression, anxiety, bipolar, schizophrenia, and then other psychiatric disorders. The co-occurring conditions, what we see primarily are hypertension, hyperlipidemia, diabetes, rheumatoid arthritis. We see a lot of CHF and COPD, AFib, and other types of heart disease. The best way for me really to speak about the patients that we serve, as I was asked to speak from a patient's perspective today, I couldn't bring our patients with us because they're too sick and they're homebound, but I did want to advocate on their behalf. So I felt I would share 3 cases with you today. Keep in mind as I'm talking about them and describing what they've gone through, if you could just keep in mind the amount of resources that we as a large health system are able to afford these people. But our goal is to continue to do our good work, but also to scale, because we do have a wait list at the time, as of now, and we also would like to remain sustainable. So the first story that I want to talk to you about is a 58-year-old female. She has severe and persistent mental illness with an extensive history of psychiatric hospitalizations. She joined our program in 2014. She lives with her mom, and her mom is also a House Calls patient. She's homebound due to her psychiatric illness and her comorbidities, which include hypertension, hypothyroid, obesity, and chronic kidney disease. She functions with the assistance of from home health aides with her ADLs and IADLs, and her caregiver support is out-of-town family support, which we find, unfortunately, frequently with our patients, which is a tremendous consideration when we're trying to keep our patients in the community. The primary concerns that our team has for the patient and the family and the patient is to manage the patient within her psychiatric illness, and we need to plan for her living situation when her mother's condition deteriorates. This woman was institutionalized in her younger years, and when she was able to be deinstitutionalized and stabilized with proper medication, she did live with her mom, and she is very dependent on her mom and is now currently, throughout the past few months, has been watching her deteriorate. Unfortunately, her mother did pass away. This patient decompensated, hospitalization was needed, and the family once the woman was hospitalized, the family realized that they weren't going to be able to maintain her at home safely any longer. So the family moved her out of state to Massachusetts, and they did find an assisted living facility for her that is going to give her the appropriate care. And as of July 2017, the family reported to us that she's doing very well and is thriving in her new environment. So we were very happy to be able to support everyone in this effort to we wanted to keep her home, but we really just, it wasn't in her best interest. The next case that I wanted to share with you is a 65-year-old female patient. She has pain management needs, and she too joined our program in 2014. She lives with her husband. She's homebound due to pain and debility from fibromyalgia. Her behavioral health issues include anxiety disorder, depression, and insomnia. Her comorbidities are chronic pain syndrome, fibromyalgia, and she does have some mild cognitive impairment. She functions independently, and she needs some assistance with her dressing. Her caregiver support is formal caregiving with a home health aide 8 hours times 5 days. The spouse is supportive but suffers from caregiver fatigue. Our primary concerns for this patient are pain control and medication management. This patient actually can go out into the community for psychiatric care, but she's quite resistant in taking our recommendation to do that. The provider for her is seeing her more frequently than typically would be seen by one of our providers. We also engage our social workers to provide supportive counseling and care management. We consult with pain management as well. The other thing about the program that I work for right now, and I'm very fortunate to be able to say this, we have a community paramedicine program, and our paramedics are especially trained to deal with our population, both with their medical issues and their psychiatric issues. We have about a 70% rate right now of keeping our patients at home, which we're very, very happy about. It's a very thriving program. The patient that I was just describing, she remains at home most of her day. Like I said, we really are trying to encourage her to seek out psychiatric support for medication management. As you'll see later on, the primary care providers are a little tentative about managing medications for our psychiatric diagnoses, and they do need support in working that through with our patients. The third case involves a 74-year-old female. She joined our program in 2015. She was enrolled with us due to an exacerbation of COPD, and she had recently been discharged from a hospice program, so she was quite ill. She lived at home with her husband. She does have a debilitating disease process. She is declining. Her psychiatric diagnosis is bipolar disorder, and her comorbidities are chronic kidney disease, COPD, hypothyroidism, dementia with behavioral disturbances. She too needs assistance with ADLs and IADLs, and her caregiver is a formal caregiver, home health aide, 8 hours times 5 days. Her spouse, again, is very supportive but very fatigued. The primary concerns that the team faces is as her physical condition declines, especially with the COPD, she becomes extremely anxious, and it really does bring out a lot of her psychiatric symptoms. This woman spent decades institutionalized, as well as the other patient that I mentioned. It took us a long time to build a trust with her and help her realize that we were going to do the best we can to keep her out of the hospital. She was very fearful that she was going to have to go back to the hospital. Her spouse is very grateful to the House Calls team. He really feels that without the intensive support of the team, the patient would probably spend the end of her life in an institution. We are trying very hard to maintain her at home. So far, we have been successful. She has not been hospitalized since she's been on our program. One of the other aspects I wanted to bring to your attention today was I did an informal survey of our providers. I wanted to really see how comfortable they were and what they thought about their what they thought about their panel size. They all carry about 200 patients each. About 42% of each of the panels, the providers felt 42% of them need, their patients need additional behavioral support. Some of their comments made on the survey were they find a high incidence of depression, anxiety, mood disorders, and undiagnosed mental health disorders, borderline personality, and substance dependency. They feel we need psychiatric assistance from professionals, which we talked about just a couple of minutes ago. It's extremely common in geriatric homebound patient population and very difficult to manage with no training in psychiatric illness. They also feel home-based psychotherapy cost is a factor, as any home care psychiatrist costs more than most of our people can afford. Having a psychiatrist paid by Medicare, join our team 1 to 2 times a month, would be very helpful. Currently, if we can find a psychiatrist that will go in the home, they'll charge between $500 and $1,000. Sorry, Dr. Harbin. And many of our family members can use behavioral health support, and we would love to have the option of video conferencing for psych support. And just some of our recommendations. Currently, the House Calls program is doing well. Our hope is to be able to remain sustainable. We need CMS's support in doing that. We recognize and implement plans that achieve the highest quality of care with a patient-centered model, having mental health needs along with co-occurring conditions while addressing payment and cost. We want to continue building on existing home-based primary care by integrating psychiatric support to our homebound patients and assist providers through consultation and medication management. We'd very much like to train behavioral health professionals to be utilized as care managers and counselors, to allow for billing opportunities similar to the COCM, support technology infrastructure to bring behavioral health services to patients through telemedicine, similar to the ECHO-like structure, Project ECHO. I do want to just emphasize, too, that the home health aides need advanced training because without them, our patients do not adhere to their medication regimen, which creates a lot of different challenges for the team with the medical issues and the psychiatric illnesses. Thank you so much.
So thank you all so much for joining us today and sharing your thoughts. We do have time for a brief Q&A session. I did want to just start off the conversation. I think there were a number of issues and suggestions made by our panelists around transitions in care, around the need to bring more behavioral health care into primary care settings to help engage people, to improve care coordination, to help overcome reticence to engage in treatment, I think is also a really important issue that Joyce pointed out. So if there were, CMMI is a wonderful place that has lots of wonderful resources and flexibilities. And I did want to just ask the panelists at the outset if there were one thing that if you could wave a magic wand and, sort of test something out, what would it be and what would you look at to really test to see whether it's had the impact you hope for? So, Henry?
I would say the one thing I would do, because it could be done immediately and would have the biggest impact, is to require the screening with standardized and quantifiable instruments in the healthcare system, the broader medical system, and the tracking of quantifiable outcome, not process measures. You can't treat effectively people, one, if you don't identify them that have these problems, co-occurring, comorbid, or just by themselves. And secondly, if most of these folks are getting some or all of their treatment in the general medical system, and you have no way to know how their outcomes are going, you have no way to adjust your treatment. The other thing is I think that would drive internal resource utilization within large medical systems, ACOs, primary care medical homes, to tracking these folks. Several people mentioned about, the STARS rating. Well, right now you can't judge a Medicare Advantage program or a hospital under a STARS or even a nursing home on how well they're doing with behavioral health because you don't have any quantifiable measures that score it. You do for the medical issues. So when you read in the newspaper that Medicare Advantage Program X is failing, through several stars, which motivates those folks a lot to do something about it, mental health and substance abuse are absent, and we do have the tools to measure all of these common things today. No more research. I would say that would be number one, because it would lead to, it would incentivize everyone to use, whether it's an alternative payment or existing payments, best practices.
Thanks, Henry. I did want to ask the community at large. I think Henry makes great points, but I know that we don't have great outcome measures right now. There are some, but I think for CMMI's work, it would be helpful if people would provide input on what it is that's really important to be measuring if they do go forward with a model.
Could I respond to that?
Sure.
Okay, so the Kennedy Forum pulled together a group of experts on quality measures and published a supplement to one of their papers listed about 20 different standardized quality. They're being used today in clinical settings so yes, it would be nice to have more measures or further refined, but you have people dying rapidly today. These are not that complicated of measures, first of all. They're symptom rating scales. So we have a number of measures now that would track the major illnesses. So I would argue that we could adopt these immediately in 5 or 6 different tools would cover most of the problems. So I guess my only worry, Kirsten, is that many people say, well, let's wait for more research, for more tools. If we have some that are reasonably good, why not adopt them?
No, I agree with you. I know they're out there. We just need to get input on what's the best set to focus on.
We have the same challenge in the specialty behavioral health system. So that's also a system that's really, for the most part, without outcomes. So any sort of piggybacking what Henry said, if you have anything in the specialty behavioral health system, I think would drive it. I know in DC, when we did provider scorecards, it was very helpful to motivate providers.
Could I add to that, Steve, I agree with that. I didn't mean to leave out the specialty system, but we should recognize and congratulate the Joint Commission, who this year issued a requirement that all of their 1,400 behavioral entities are going to have, starting next January 2018, have to start using standardized quantifiable outcomes patient tracking tools. So that is the specialty system. Yeah.
And actually, Famarion has developed an outcomes management system that has potential too.
Anyone else want to add anything at this point? No. Okay. Hello.
It's one of the best for computerized adaptive testing for all domains of human function, including emotional health and cognitive functioning. So I think that would be an easy pick. It's cross-validated against the PHQ-9. But my question was, so we have behavioral health APMs are well and great, but the other part of it should be getting existing APMs to work better for behavioral health. Health Affairs articles in 2014 found that ACOs weren't doing a good job for behavioral health. And in 2016, it found that risk adjustment as a whole, like the way we're calculating the amount of payment providers are getting, is just off for behavioral health entirely. So how do we do the APMs we have now, like ACOs, which are based on benchmarking, based on historical spending data, or Comprehensive Primary Care Plus, where care management fees are based on the hierarchical condition codes, which are based on past spending, when we have not been spending on behavioral health, especially in primary care?
Thanks a lot. Well, I'm not sure quite how to answer that. I think that is a issue, but it's not the predominant issue or barrier. I think when one is setting rates for any type of flexible payment, you almost have to start from scratch to some degree, depending on what bundle of services you're putting in there. But I think Patrick Kennedy's earlier comments and yours, Nathaniel, are important, that if you're going to go off a historical payment rate for psychotherapy or whatever, you do have to look at whether or not that was an adequate rate. But I don't know. I don't think that's a major barrier. I think that's, and I would like to qualify that we got some recommendations of existing alternative payments from different people, and one of them did have the detailed rates, and we said, well, we don't want to publish those. We don't want those. So I think just to reassure people, what we want is like how you constructed these things and what were the services, et cetera. I realize that there's going to be another level of complexity with you and your actuaries about how to set the actual rate for that bundle.
Hi, I'm Dr. Scott Zeller. I'm here representing today the National Coalition on Psychiatric Emergencies, which is an organization which combines leadership from major mental health organizations, psychiatry organizations, emergency medicine, and patient advocacy. One of the most underserved mental health communities would be those of the highly acute emergency mental health patients. Today, they end up in emergency departments. There's a natural assumption that if they're there, they need to be hospitalized. And so they end up being stuck in the back of an ER, sometimes for days, sometimes even for weeks, waiting for an elusive inpatient bed. It's a strange approach when you think about it, because if you came in with, this, let's say, an asthma attack, they'd try to treat you in the emergency setting, not tell you, here's a sitter in the back hallway, we'll see if we can find you a hospital room tomorrow. So there's several different approaches that actually could be done in the emergency setting that would help reduce the need for inpatient beds, maybe open up more inpatient beds. But right now, there's really not a good way to fund them. I appreciate what you said before about removing some of the obstacles for billing for telepsychiatry, because emergency on-demand telepsychiatry is one possible solution. There's another one, and that is the alternative ER that's specifically for psychiatric patients that often can be adjacent to the ER, maybe in a separate location. Right now, there's reimbursement for that with Medicaid in some states, but Medicare is an awful reimbursement, virtually nothing for that. And what's really neat about these units is that people who 100% of them would have been hospitalized in a standard system, and 50% or more would be in physical restraints. In these alternative units, there's usually only 20 to 30% end up needing hospitalization, and less than 1% need physical restraints, because just getting them out of that ER setting causes, makes all kinds of differences. So the question being, here we've got this great situation where if we could fund these alternative units, you'd actually end up saving money, because if it costs $1,000 per patient in a psych ER, and you can avoid hospitalization in 3 out of 4 of them, it means for every $4,000 you spend, you might save $20,000 or $30,000 in hospitalizations. What my question then to you is, how can we advance this idea and maybe see if CMS can consider looking at funding, just regular coding for these kind of things, because we're not even asking for funding or startup costs. We think that if there was a way to get reimbursement for these services, that actually, people would be, hospitals and different organizations would start them on their own. As long as they're self-sufficient, it saves $2,500 every time you get somebody out of the ER into a psych setting. And, you're saying, well, there's an alternative to hospitalizations. So, interested in your thoughts on this.
Yeah, I don't, go ahead.
No, I would say I'm thankful for your comments as someone who worked in an emergency room for 17 years and who, often found hospitalizing someone who I knew didn't need to be there really, and where I knew treatment was not going to happen. And was actually discouraged from using codes in the emergency room that would imply treatment or would imply or were even related to suicide risk. And so I think that an overhaul in terms of the reimbursement and because you can actually provide some treatment in that setting that can be very effective, and the ability to support some of those follow-up services or related services that you talked about, I think would be critical. So,
I know in D.C., when I ran D.C., we had a standalone psychiatric emergency program called CPEP. It was not affiliated with a hospital, and probably 5% of the patients needed to be referred out for medical. So we basically wanted to change that and have it connected to an ED. So I think you're right on the design. Our numbers were about 30% were admitted, and that entity was very well connected to the community provider. So if somebody was on an ACT team, somebody who came up, they knew who they were, they called them and came in. I've been in Baltimore City on second go-round, just helping looking at stuff, and the city data is approximately 65% of people who have a psych consult in the ER end up getting admitted. So that's the interest of the number. In DC, it was all part of our mental health rehab services. There was a code for crisis billing, but it was used somewhat in that. But
Could I add one thing to that? I think it's a generic thing. I mean, when you hear Steve talk about an innovative program where they worked this out, right? You came up with a code, you had that service. There are a lot of things that have happened in the public mental health system where they had flexible grant money or they had a waiver from Medicaid. So I have two suggestions for you, as well as other people here, is one of the reasons these things don't spread out to everywhere is that they don't get proposed in a specific manner to payers. This is true. One of the things we were going to talk about was the RAISE program, which is a good example. There's a very innovative early first psychosis treatment program. And it's paid for by some Medicaid and some by grant money, but it's not paid for by routine insurance. So one of the hopes of the scattergood paper, I would suggest if you propose something, we'd like to include it in this paper. But when we're hoping to issue a final paper in October, so we're hopeful people from this meeting, if you're interested in adding to that, that would be a good example. But my request would be to try to flesh out the details of what you're asking for. If you go to an insurer, it's a little bit like being in a Shark Tank meeting, any insurer, right? I've been there for 20 years, so I know. And so it needs to be really clear what you're asking for, what's the justification, how do you propose it, and where it fits.
Thank you.
Hi, I'm Damian Cabezas from Horizon Behavioral Health in Central Virginia. Thanks to CMS for hosting this conference and for the speakers and panelists that have provided some insightful information. We serve consumers. 80% of our reimbursement comes from Medicaid, so my question is going to be for payment. Because I wholeheartedly agree with value-based services and the movement in that direction. Long overdue. But it does come down to what Patrick Kennedy said earlier. Insurance, we need consumers to have insurance, and it comes down to a funding issue. I haven't, while I've heard of value-based reimbursement being talked about, I haven't heard about discussions that have happened regarding the transition from Medicaid from a federal and state partnership to a block grant. And I'm curious as to your thoughts on that, because I have real concerns, I'm sure others do also, especially for states that reach that cap and then having to make these very difficult decisions.
Yeah, I don't think we disagree.
Yeah. It's a worry.
Yeah.
Okay. So, but no sort of, no sort of new information about that. Yeah, okay.
I would
Thank
only
you.
say that it doesn't matter what the reimbursement structure is, whether and what caps. There are limits now on many of the current things not having a block grant. That could be obviously a major problem depending on how it's done, but it also calls the need more for more efficient payment mechanisms, whatever the structure is. So I think we're trying to figure out, well, how do you do this better, whatever that payment structure is, right? Block grant, non-block grant, et cetera.
And we are running short on time, so if people could really stick to asking their questions, that would be helpful, so everyone has a chance to speak.
Hi, my name is Elizabeth Born-Traeger, and I'm a psychiatric nurse practitioner with Team Health. I manage a group of 55 providers where we provide psychiatric services in 350 long-term care buildings in the Southeast. My question is related to the 5-star rating system and how that's negatively impacting the treatment of comorbid medical and psychiatric conditions. Right now, if I have a patient who's admitted to a facility and they have a history of bipolar disorder and they also have a hip fracture, if they are on an antipsychotic medication, the facility is negatively impacted by the fact that they are on that antipsychotic for something other than schizophrenia. The result of this is that we have several psychiatric diagnoses that are being mistreated or undertreated in the long-term care setting. As you know, if you take somebody who has severe and persistent mental illness and you don't treat that while trying to treat their medical conditions, the outcomes are not as good. So my question is, number one, why is schizophrenia different in its treatment or its view from CMS for the 5-star rating with the antipsychotics? And then number two, what is being done to address this? Because it's truly a treatment failure for our population.
So since that sounds like a question for CMS more than the panel, I'm going to defer that to, being addressed through response to a comment being submitted. I don't represent Medicare, so I can't speak to that myself. I mean, I think this panel and the efforts going on here really represent the interest at CMS in addressing the needs of people with serious mental illness. So thank you for your comment.
Okay, thank you.
And again, please, we're running out of time. Please stick to asking questions of the panelists. Thank you.
Hi, I'm Richard McKeon. I'm the chief of the Suicide Prevention Branch at SAMHSA. My question for the panel is this: we lose people on an ongoing basis to suicide after they're leaving inpatient units and emergency departments. Verna, you referenced the importance of care transitions. What do you think we can do to improve the financing? Because it's not a clinical issue, it's a financing and organization of care issue, that we are not more effectively working with people.
So I think what we need to do is broaden our definition of transition so that not just a transition from hospital, but from other settings as well. And I think a modification of what the documentation requirements are for the transitions of care reimbursement to be more fitting, for lack of a better word, for people who are at risk for suicide or getting discharged from psychiatric facilities. And I think the ability to really broaden what is reimbursed around transitions of care and allow for the treatment to start within the facility and really provide an appropriate and adequate transition. And I know one of the struggles is that we're beginning to start the very specialized CBT for patients at risk for suicide, and I'm not getting reimbursed for that treatment that we're starting in the hospital prior to their discharge and transition.
So I think at this point, we're going to have to shift to transitioning to lunchtime. I'm very sorry. We do have the CMMI BH Summit at ketchum.com inbox, so I encourage you to submit your questions and comments there. So join me again in thanking our panel.
Okay, everyone, we have 1 hour for lunch. If you, everyone knows where the cafeteria is, or if you don't, just follow the crowds that way. If you pre-ordered your lunch, it will be available for pickup in the cafeteria, and the CMS escorts can show you where that'll be. We'll see everyone back here at 2:05.